Good morning, everyone, and welcome to the 2021 Clinical Challenges in Primary Care. We are so excited this morning to have you with us for a bit of education and information sharing. So I think we're going to go ahead and get right to it. So thanks again for joining us today for Clinical Challenges in Primary Care. And before we get started this morning, a few housekeeping notes. The first thing I'm going to talk about is getting our credit for these slides or for the presentations today. And see if we can put that slide up with the credit information. So there we are, claiming credit, very important today. So AMA PRA Category 1 credit is available for attendance at this event through VCU Health Continuing Education. Claiming this credit, the important part here, is a 3-step process. First, if you have not yet enrolled in our attendance system, you'll need to text to the email address you used to register for this event. You'll need to text the email address you used to register this event to 804-625-4041. And this is a one-time operation. Second, all participating claiming credit will need to text today's text session code to 21520 to that same number, which again is 804-625-4041, and that is to record your attendance. And at the end of today's session, the event evaluation will be accessible in your CME Cloud event. If you have any questions or problems, please email ceinfo@vcuhealth.org. Those folks will be more than happy to troubleshoot with you and make sure you get the credit. And I do want to just remind everyone that we will have time for Q&A following each of today's presentations. So if you're attending live, you can submit questions via the chat feature on the right panel at any time during the session, and we'll do our best to address every question, as many as possible. We want to be very cognizant of everybody's time this morning. So also a reminder that today's session will be recorded, and the PowerPoint presentations will also be available for your reference via the CME Cloud app and the website. So we have our little housekeeping rules set. We will have those slides cycle throughout the day, so don't feel rushed or stressed that you've got to do that right now at this moment. And here we are, right in the beginning of our presentation, and we are ready for our COVID-19 update from our very own Dr. Emily Godbout. So I have the pleasure to introduce Emily Godbout as she provides us with an update on COVID-19. Dr. Godbout is an assistant professor of pediatrics at VCU, specializing in pediatric epidemiology. She also directs the Pediatric Antimicrobial Stewardship Program at Shore. Dr. Godbout attended the Philadelphia College of Osteopathic Medicine and completed a residency and fellowship right here with us at Shore. She holds an MPH from VCU. Dr. Godbout has guided our providers in our care and prevention of COVID-19 of the COVID-19 infection. Thanks for being with us, Dr. Godbout. And now I will turn it over to you.
Good morning, everyone. Thank you so much for joining me, and I'm so happy to be here. So today we're going to talk a little bit about COVID-19 vaccines for children and adolescents. Apparently this was a requested topic, so we're going to go through everything that we know to make sure that y'all are up to date. I do want to give a special shout out to a couple of my colleagues whom I edited some slides from or adapted. That's Dr. Donowitz, Dr. Kimbrough, and Dr. Michael Stevens. So thank you to all of them for making this presentation even better than it already was. So I always like to include this bat in a lot of my presentations if you've heard me speak before, but I wanted to let you know that I don't have any financial disclosures. And then I want to remind you that bats are these really amazing natural reservoirs for viruses. They can hold up to 200 different viruses in their body at any time. And this is really because they have this really high metabolic demand for flight. And it causes DNA damage and the release of self-DNA into their cytoplasm. So they have this altered DNA sensing pattern or system so that they don't destroy their own DNA. Therefore, they can't recognize a lot of viruses. So unfortunate for us, they are this really, really crazy resource for all sorts of viruses, which is probably where this original coronavirus started. So I know that this has been a really crazy year and a half. I feel like this guy, Jim here, who he's only 35, but he looks a little bit older than that. This is definitely what's happened to me in the last year. And I'm sure that a lot of you on the line feel the same way. And a lot of you may be really, really tired of hearing about COVID. But I think with the vaccines, we're really going to move in the right direction. And maybe we'll talk about it less and less as we go forward. So a couple things that we're going to do today. We're going to review the status of COVID-19 vaccines, vaccination in the United States and the state of Virginia. We're going to talk a little bit about what's available. And then we're going to specifically talk about what's going on in pediatrics, what trials are going on, what do we know about vaccines in children. And then we're going to talk about some side effects, commonly encountered questions that you may get from parents, and talk a little bit about vaccine hesitancy. So this is a couple days old, so we may have higher percentages. So this is as of 4/20. But if we look at our US population, over 133 million people have received at least one dose of a COVID-19 vaccine, and over 83 million people are considered fully vaccinated, which is about 26% of our population. If we look at our population greater than 18 years of age, about 33% of our total US population is now considered fully vaccinated. So I know that we're all celebrating because that seems really good, about a quarter of our US population. And it's definitely 100% a step in the right direction, because those that are vaccinated are unlikely to develop severe disease, unlikely to be hospitalized and die. But even though we're getting these vaccinations, it's still important to remember that we still do need to mask and socially distance when we're in public for this time period. A lot of people have asked, so at what point do we think we're going to sort of reach that herd immunity that a lot of our population will be protected? So Dr. Anthony Fauci, who's the chief medical advisor to President Joe Biden, also the head of the National Institute of Allergy and Infectious Diseases, he feels for the US to reach herd immunity, we'd likely need 70 to 85% of the population to be immunized. Even though he says that, and we all totally respect him and love Dr. Fauci, we don't truly know what percentage would halt the spread of the virus. And we also have to take into account things like new strains or new variations that may have already entered our community and then may continue to enter into our community. One good way to think about herd immunity, and one good way to potentially explain it to some of your pediatric patients, is that they can imagine this really, really big forest. And 80% of the trees have been treated with a flame retardant. And if there's a forest fire, that flame retardant will prevent devastation of the forest and protect most of the trees, right? So it's sort of like our population. So if we get most of the people vaccinated, and a global pandemic occurs, or we're in the middle of a global pandemic, we should do a pretty good job at protecting a lot of people in our community. And it's a good way to think about it, because it's sort of a altruistic way to think about it as well, because our kids will get vaccinated, we'll get vaccinated, and it'll help protect us and our families, but then also everybody around us as well in our communities. So what about in the state of Virginia? How are we doing? So we have a little over 2 million people who are fully vaccinated in the state of Virginia, which is about 26% of our total population. And most of those vaccinations have been administered at local health departments and pharmacies. Medical practices and other community health providers are vaccinating, but it accounts for a much smaller percentage, as you can see here. You might be wondering, well, what percentage of vaccines in the state of Virginia thus far have been allocated to children? So children age 16 to 19 years of old account for about 2.6% of all vaccinations in the state of Virginia. Remember, only one vaccine, the Pfizer vaccine, has emergency use authorization down to age 16. So it's kind of like the only tool we have right now to vaccinate children. And until recently, and children that are 16 years of age and up, and until recently, in the state of Virginia and across the country, these children kind of had to have specific risk factors to make them eligible for the vaccine. But as you all know, that was lifted just recently. In the state of Virginia, Governor Northam announced that all individuals in Virginia age 16 and up will be eligible to get the COVID vaccine starting on Sunday, April 18th. This was one day before Joe Biden said that this could happen for the entire country on April 19th. So we were one day ahead. Not sure why we wanted to sneak in there one day ahead, but we did. And then this is Northam at the press conference saying, you know, the COVID-19 vaccine, it's the light at the end of the tunnel. The light's getting brighter every day as more Virginians get vaccinated. So what vaccines do we currently have available to us? And this is literally ever changing, as there was some new information that came out literally last night about one of the vaccines, and we'll talk about it. So really we've got 3 vaccines that have emergency use authorization. Pfizer, which is an mRNA vaccine, and it's for children 16 years of age and then up through adulthood. And then Moderna is only available 18 and up. And then the Johnson & Johnson vaccine, which has been in the media quite a bit lately, is available for 18 and up. So as of before last evening, I would have told you that the Johnson & Johnson vaccine was on pause. So the FDA and the CDC called for immediate pause in the use of the Johnson & Johnson vaccine a little over a week ago. We were awaiting on further evaluation until last evening when the news sort of broke that the FDA and CDC feel that the known and potential benefits of the Johnson & Johnson COVID-19 vaccine outweigh its known and potential risks in individuals ages 18 and older. And so they suggested to resume giving the Johnson & Johnson vaccine, which could potentially happen as early as today at some sites. I know there was some concerns that how are we going to vaccinate all these people in the US with one of the vaccines sort of on pause? So, you know, I guess we are going forward with it. And the FDA, the CDC, everybody feels that it's safe, that the decision was easy, and overall the rate of events, which we'll talk about what those events are in a minute, was 1.9 cases per million people. So what exactly are we talking about? Why did they pause it? So they paused it due to a clotting syndrome that they saw being reported. This is different than just a standard blood clot. This clotting syndrome is a rare process, a cerebral venous sinus and splenic vein thrombotic event with thrombocytopenia. At the time that they paused it, there were 6 cases of this in US women aged 18 to 50 who had presented within 2 weeks of vaccination. And there was actually 1 death associated with this, and that 1 death did take place in the state of Virginia. This is actually similar to a syndrome that I was described in about 200 people in Europe who received the AstraZeneca vaccine. And so I wonder, my theory is there some type of potential class effect with the adenoviral vector vaccines, since we're not seeing this same thing with the mRNA vaccines? So the normal risk is probably 1 per 250,000. That's sort of the baseline. And as I mentioned previously, they were finding 1.9 cases per million. So really, it doesn't really appear that there's this significant increased risk with the vaccine in comparison to the background rates. Which is hence why everybody felt comfortable with moving forward with that. All right, so a little bit more background on the vaccines, and then we'll get specifically into the trials with children. So Pfizer and Moderna are both highly effective at preventing COVID-19. For Pfizer, it's about 95% efficacy after 2 doses separated by 21 days, whereas Moderna is 94% after 2 doses separated by 28 days. The Johnson & Johnson vaccine is 77% from their US studies, and in their South African studies, the effectiveness was only 64%. So we have to take that with a grain of salt because the Pfizer and the Moderna studies occurred early in the pandemic when there was less variance in our communities and all over the world. And the Johnson & Johnson study happened much later in the pandemic. And they had a large study site in South Africa, and there is a very specific variant that comes out of South Africa. And so some people question if Pfizer and Moderna right now are doing booster trial studies, looking at a third booster and potentially looking at, are we going to need this vaccine every single year? And so I'm interested to see if the effectiveness of the vaccine will be different doing it at this point in the pandemic. So time will tell. How long are these vaccines effective? We don't know for Johnson & Johnson, but for Pfizer and Moderna, they have already published a lot of data that shows that the vaccines are effective for at least 6 months, possibly a year or more. Again, time will tell us exactly how long it's effective for, but I know at least some of the companies, Pfizer in particular, has come out and felt that probably we'll need a yearly vaccine, sort of like the flu shot. Just a couple key considerations. For the Pfizer vaccine, long-term storage requires those ultra cold kind of freezers stored at -94 degrees Fahrenheit. Moderna, you can keep up to 30 days at 36 to 46 degrees, similar to Johnson & Johnson. The benefit of Johnson & Johnson is that it's only 1 shot versus Moderna and Pfizer are 2. So we talked a little bit about Johnson & Johnson and the clotting disorder. There was some concern early on for potential for anaphylaxis with Pfizer and Moderna. And what we found is that it's really, really low. For Pfizer is 4.7 per million and Moderna is 2.5 per million, which is really not all that different than some of our other routine vaccinations. It's probably actually a little bit less in comparison to some. So that really hasn't panned out to be a major concern. So just basic on how an mRNA vaccine works. An mRNA vaccine introduces an mRNA sequence for a SARS-CoV-2 antigen. In this case, they use the spike protein. They introduce that into the body and it primes the immune response to subsequently be able to react to an actual virus exposure in real time. Some of the advantages of the mRNA vaccines are that they are faster and cheaper to produce. They do not contain inactivated or live virus. They don't incorporate into the DNA, and the mRNA is broken down by the body rapidly. So you might be wondering, well, how can I explain this to one of my adolescent patients or my preteens in a way that they can help understand, since the mRNA vaccines are relatively new technology? I really like this Twitter message where it's explained as, all right, the mRNA vaccine doesn't actually contain the virus itself. And you can think of it as an email sent to your immune system that shows what the virus looks like, instructions to kill it, and then, like a Snapchat message, it disappears. So it's truly amazing technology. I feel like our teens and preteens will really understand that. Like, I actually don't understand that explanation as well as the other one because I don't really know what Snapchat is. So there's a lot of variants out there in the community and across the world. These are just a couple variants where we have a little bit of information about. The B117, this is known as the UK variant. There's concern that its transmission is increased up to 70% potentially, and that there is increased death with this particular variant. But good news for us is that the effect on vaccine effectiveness we think is pretty minimal. The South African variant, we're not really sure how the mRNA vaccines will fare with that, but we do know that for the Johnson & Johnson vaccine, it's probably about 64% effective. And then the P.1, this is a strain from Brazil. We really don't know all that much about it, but we think that the impact on the vaccines is probably minimal. You know, there's been a lot in the news about the variants and the vaccines and how effective they'll be. And I think still at the end of the day, these are variants, they're not totally new viruses. And so the vaccines are still going to offer some level of protection and will probably still help prevent some of those more serious complications like hospitalizations and death. And so I don't think that, I think we're going to be okay, but it does mean that, you know, we may require boosters each year. I don't think it's a reason not to get the vaccine. Okay, so what is the current status of COVID-19 vaccine trials in children? What do we know so far? When can we vaccinate children younger than 16? So first, this busy what is this, a chart? This busy chart here is looking at the Pfizer vaccine. These are all the clinical trials that are going on right now or have been completed in the US for the Pfizer vaccine. So first, I just want to draw your attention to the original clinical trial for ages 16 and up. This was already been published. This was in the New England Journal of Medicine. This study is a study in which is sort of the reason of why we're using this vaccine right now. And we're going to review that one really quickly. So remember, this included children aged 16 and up. So there were 43,000 people that volunteered for this clinical trial. The researchers blinded them into two groups, and they were blinded, so they did not know which group subjects were in. So about half got placebo and half got the vaccine. And of the children who got the vaccine, and children here is defined as age 16 to 17, it was a very small number, but it was 754 children. And in this particular age group, we presume that their immune system really probably acts very similar to the immune system of an adult. So even though that N was really small, we still think that, again, their immune systems are very comparable to a lot of the other people in the study. So the researchers followed each group. They wanted to see how many people developed symptoms of COVID-19. And when people developed symptoms, they were tested for the disease. And then they decided to make it statistically important, they would have to find 170 cases of COVID-19 and at least 10 severe cases. So one of the criticisms when this study first came out is that they only tested people who presented with symptoms of COVID-19. And maybe there was this whole population of people who had been vaccinated and who were asymptomatic and we didn't know, and they had COVID and then have the ability to transmit COVID. Other studies have come out since then where we really think that the vaccines also work well as far as preventing, asymptomatic infection, that we don't have, you're not vaccinated and then there's still a possibility you could develop the infection, but it's certainly much less. Okay, so what did they find? They found that there were 162 cases of COVID in the placebo group and 8 cases in the vaccine group. And this is where the quote of 95% efficacy comes from. And of the people who had more severe disease, 9 were in the placebo group, and then there was 1 in the vaccine group. So this is published, New England Journal of Medicine, it's out there. This is what helped us go ahead and get the emergency use authorization for our adult population, and then our kids down to age 16. This is just comparing the placebo to the Pfizer vaccine and looking at the cumulative index of COVID-19 infections. Okay, so we all know that, but what about our kids that are younger than 16? So Pfizer completed enrollment in January of this year for 12 to 15-year-olds. And then they just released a press release about a couple weeks ago at the end of March that the vaccine was 100% effective for 12 to 15-year-olds. And let's take a little deeper dive and look at that data. So this is only released as a press release. It is not published or peer reviewed. And I anticipate we'll be seeing this data soon. We just haven't seen it come out yet in a publication. So they had 2,260 kids between the ages of 12 and 15. And again, they found that that Pfizer vaccine was 100% effective and that the kids had really robust antibody responses, actually exceeding the antibody responses when they compared it to people who had received the vaccine that were between the ages of 16 and 25. There were 18 cases of COVID observed in the placebo group, and there were 0 in the vaccinated group. And then the SARS-CoV-2 neutralizing antibody mean titers were actually higher in this group than in the 16 to 25-year-old group. But in the press release, they said it was non-inferior. So they didn't provide any statistical analysis, but I'm assuming that when they did it, they didn't find any statistically significant difference, but we'll have to see. And then the side effects in our kids down to age 12 were very, very similar to those that were in the age group of 16 to 25. So they actually submitted data to the FDA for emergency use authorization on 4/9, so just about 2 weeks ago or so, to be able to vaccinate kids in this age group. So this is not starting over with an emergency use authorization. This is an expansion. And so I think that it's possible the FDA may approve this maybe even as early as May. So we might be in a situation where we'll be getting these kids vaccinated in May and June. We'll just have to see, but I don't know why the FDA would really prolong it. So I feel very, very, very confident that our kids down to age 12 will definitely be vaccinated. Those who choose will have the option of being vaccinated before the start of the school year. So what about our kids that are younger than 12? So again, we're still talking about Pfizer. So they have started enrolling children for a clinical trial with kids 6 months to 11 years of age. They started enrollment last month in March. This is a 2-phase study, and they're going to test 3 different doses of the Pfizer vaccine, and each dose will be assessed in the 5 to 11-year-old group, the 1 to 4-year-old group, and then in the 6-month to the 2-year-old group. After determining which dose is the most effective, Pfizer plans to go on and then vaccinate about 4,500 children. I do not anticipate that we will have data from this trial before the start of the school year, definitely not. Unlikely that we'll have a lot of data from this and be able to start vaccinating in this year, but I think at some point in 2022, we'll definitely be there. There's a possibility that older age range, kind of the 5 to 11-year-olds, they may push that forward and we may get that data sooner and get it, towards the end of 2021. We'll just have to see. But they have started enrollment. For the Pfizer vaccine, I don't think there are any clinical trial sites that are that close to Richmond, Virginia, or to our community. So I don't know that it's something that would be easy for our patients to get to if they were interested in enrolling in a trial. we're going to switch gears. So that's everything that's going on with Pfizer and with children. We're going to switch gears to Moderna. I always wonder if Moderna is sort of kicking themselves because in their original study, they didn't include children younger than 18. They just included 18 and up. But if we look at that top row there, they have completed enrollment for a clinical trial for children aged 12 to 17. They've enrolled about 3,000. Again, this is very similar to the Pfizer study. We just haven't seen a press release come out or any data come out from that. I thought maybe once Pfizer came out with their data, Moderna would come out with theirs, but we haven't seen it quite yet. But I anticipate Moderna will not be very far behind, and that we'll start seeing data from their study as in kids as young as 12 pretty soon. If we look at the next row down, Moderna is also looking at a clinical trial for kids 6 months to 11 years of age. And again, it's very similar to Pfizer, where it's a 2-phase study where they're going to look at the doses in specific age ranges. And then once they determine the appropriate dose, they'll go ahead and vaccinate X number of children. And they also started enrollment last month. The Johnson & Johnson vaccine, there are clinical trials planned in children, but as far as I know, none in the US. I know they have a small study going on in, I think, Germany, Spain, potentially Netherlands, age 12 to 17. I know that was paused at the same time that the pause was put, for the adults receiving the vaccine. And so they may look into resuming that study relatively soon. But as far as I know, there's no clinical trial sites in the US for a Johnson & Johnson vaccine trial for children. This is kind of old news now, since yesterday the FDA and CDC, again, as I said, are recommending to go forward with the Johnson & Johnson vaccine. Just briefly, this is a little bit of information about the Moderna phase 3 trial that included 18-year-olds and up. They had about 30,000 volunteers. About half got placebo, half got vaccine. They were, again, blinded. We didn't have any children less than 18. And they were looking to get 196 COVID cases and at least 30 severe cases. Again, they only tested people with symptoms. And ultimately, they found 185 cases in the placebo group and 11 in the vaccinated group. And that's where you hear that 94.3% effectiveness from. So there is a Moderna clinical vaccine site trial in Richmond, Virginia with the Clinical Research Partners. That's a group that began in 2011, and they provide high quality clinical trials to our community of different medications, different vaccines to the Richmond, Virginia area. They started enrollment for their Moderna Pfizer trial 6 months to 11 years of age this month. So it's a potential, just throwing that out there so you know about it if you know any kids that would potentially be interested in enrolling your own children, or if a parent asks you, there is a clinical trial site in Richmond, Virginia. Of course, there's a lot of other vaccines. We're not going to go into all that. They are doing a small test of the Oxford AstraZeneca vaccine, which is mostly, it's not used in the US, it's mostly used elsewhere. And I believe they already started that trial. And then there's the Gnrh, which they do plan to do a trial in pediatrics, but we don't really have much data from that yet. So really our big ones for us and in the US are going to be the mRNA vaccines for children. So just to recap, what do we know? As of today, this moment, Pfizer has an emergency use authorization for age 16 and up. But they have already applied to expand it down to age 12. And so we anticipate that this age group will definitely be able to be immunized before the school year. And I think that the emergency use authorization will be approved by early May. So we may be able to start before the summertime and getting some of these kids vaccinated. And then they're already testing the vaccine in kids 6 months to 11 years of age. Moderna, we can only give it to those that are 18 and up. They have tested the vaccine in kids that are 12 to 17 years of age, and we anticipate having data from this trial soon. And they have also started enrollment 6 months to 11 years of age last month. And Moderna, there is a clinical trial site in Richmond, Virginia, at the Clinical Research Partners for the Mrna Vaccine trial for kids less than 12. All right, so I don't think that there's going to be any trials or looking at the vaccine in kids that are less than 6 months of age. And this is not uncommon to what we have for some of our routine childhood vaccinations. You know, look at our flu vaccine. We don't usually, we don't give that until 6 months of age. So there might be some parents out there, or you might be wondering, well, how can we protect our youngest patients? So I wanted to first go over this study that came out just on Wednesday from the New England Journal of Medicine, looking at the mRNA vaccines in pregnant women. So multiple professional organizations have come out and supported pregnant women and breastfeeding women in getting the COVID-19 vaccines. There are ongoing clinical trials right now looking at the safety and effectiveness of the vaccines in pregnant women. We just don't have that data yet. But these researchers looked at the safety of the vaccine in over 35,000 pregnant women who received the vaccine. So to date, this is the largest report on COVID-19 vaccination and pregnancy. And what it does for us is it really just bolsters that the vaccine is safe to receive while pregnant. So they looked at data from December of last year till February 2021. And this is descriptive data from the VSafe pregnancy registry and then the vaccine event reporting system. So VSafe is the CDC's smartphone-based tracking system where you could register and report any symptoms, report if you were pregnant, etc. And then the event reporting system is when people actually report adverse events. And there they would indicate if they were pregnant or not. So the key findings, injection site pain was reported more frequently among pregnant persons or women than non-pregnant. And then pregnant women were much less likely to have headaches, myalgias, chills, and fever. So we can't directly compare this, but the calculated proportions of adverse pregnancy and neonatal outcomes in persons vaccinated against COVID-19 were really similar to our background rates or the incidences that we normally see. Even though we can't technically compare it, I'm just going to compare it here for a minute. So the pregnant people who received the mRNA vaccine experienced about a 14% with pregnancy loss, and the baseline in the United States for pregnancy loss is 15 to 20%. So that seems in line with what we typically see. 9.4% of women who received the mRNA vaccine experienced preterm labor, which is similar to the baseline, which is 10%. And then 3.2% of pregnant women had a small baby SGA at 3.2%. Whereas our baseline is typically 11%. So again, these preliminary findings show that there were no obvious safety signals among pregnant people, and really, again, bolsters that this is likely safe for pregnant women. The researchers of this study, though, do say ultimately we really need to have more longitudinal data. So a lot of these women that received the vaccine have not, are still pregnant. I mean, they haven't had their babies yet because this is all still so new. So we should have more information in the future regarding its safety, but everything sort of looks like it is safe in pregnant women. This was a study that also just recently came out looking at the COVID-19 vaccine response in pregnant and lactating women. So the study period was December 2020 to February 2021. This was a prospective cohort study from two academic institutions, Mass General and Harvard, and they had 131 participants, so a really, really small N, but 84 pregnant women, 31 who were lactating, and 16 non-pregnant. Most of the patients who participated in this study were white, non-Hispanic, in their 30s, and they were for the most part healthcare workers. So they looked at, these women provided blood and or breast milk after each vaccine dose, and then 2 to 6 weeks after the last dose, and then at delivery for the 10 who gave birth during the study. So again, we only have information from 10 women who actually gave birth within the study time period. In the 10 women who delivered, antibodies were detected in both their umbilical cord and their breast milk. Vaccine-induced antibody titers were essentially the same in women that were pregnant, lactating women, compared to non-pregnant women. And they note in this study that these levels here, these antibody titers, are actually much higher than in women who are recovering from a natural COVID-19 infection. We've seen that with other studies as well, as that the vaccine response seems to be more robust than the natural immunity that we get when we have the infection. Within this study, all the groups had a similar side effect profile. And again, as I mentioned, in the 10 women who gave birth, all 10 of the babies demonstrated antibodies in the umbilical cord and also in their breast milk. So some data to suggest that our moms, our pregnant moms or our breastfeeding moms, are able to transfer antibodies to babies, which again, we see with a lot of other vaccines. That's why we vaccinate pregnant women with things like flu and pertussis, not only to protect mom, but also so that she can pass on some protection to her baby. This was a study that just came out in the beginning of this month looking at SARS-CoV-2 specific antibodies in breast milk after COVID-19 vaccination of breastfeeding women. So this is specifically now in breastfeeding women. There were 84 participants. This didn't occur in the US. This was in Israel, but it was from December 2020 to January 2021. And really what they found was that there was a robust secretion of SARS-CoV-2 specific IgA and IgG antibodies in breast milk for up to 6 weeks after the second vaccine dose. So I just want to draw your attention here to the first graph. This is looking specifically at the IgA levels. So IgA secretion was evident as early as 2 weeks after vaccination, and then kind of spiked again after the second dose at that 4-week time period. And if you look at the second graph here, you see that there was a spike in IgG after 4 weeks, so a week after the second vaccine. So again, this is giving us data that suggests that these breastfeeding moms were able to pass on immunity to their infants who are breastfeeding for at least a specific time frame. Some limitations of this study, it's a really small N. They also didn't perform any functional assays, meaning when they tested the antibodies, they just quantified how much was there, but we don't actually know how effective they are if they were neutralizing antibodies. So just a couple take-home points about how we can protect some of our youngest patients. Again, multiple professional organizations feel comfortable in pregnant women making the choice to get the vaccine. And now we have this really huge study that came out from New England Journal of Medicine this week that didn't show any obvious safety signals and really bolsters our confidence in that recommendation. We also have a couple studies, although small, that suggest vaccinated pregnant women or breastfeeding moms, they may provide protection against COVID-19 via placental transfer or via their breast milk. We don't know the duration of protection. How long will these babies be protected for? At least in the scenario with breastfeeding moms, we know that they're at least receiving some protection for at least up to 6 weeks after the second vaccine dose. All right, how are we doing on time? We're doing okay. It's about 15 more minutes and we'll do some questions. So I do anticipate that there'll be a lot of parental concerns and potential vaccine hesitancy as we move forward in vaccinating children. I say that though, and then a lot of my colleagues that I know have children, the kids are just so excited to get the vaccine, and then the younger kids really want to jump on board and get the vaccine. But this is just my perspective of the people that I hang around with and know. So I know that there's a lot of people out there that probably don't share that same excitement for their children to get the vaccine. This is just, I couldn't find a lot of data. There's a lot of like social media posts and news stories about what percentage of moms say they'll let their kid get the vaccine, and it's all sort of just not peer reviewed. And I couldn't really find a good study. This one is also not that great, but it's at least something. This was from Indiana University. They surveyed about 2,000 parents. This is on a preprint server right now. It's not peer reviewed, but sometimes we see these eventually get into a peer reviewed journal. This was a mixed method study in Southern Indiana. They found that 34% of moms did not plan to vaccinate their kids. But in contrast, I thought this was interesting. Only 17% of fathers said they don't plan to vaccinate their children. A couple issues with this study. This data is from about a year ago. A lot has changed in the last year, and so parents may feel differently. This isn't peer reviewed, and then this is only from one geographic location in our country, from Southern Indiana. But I've seen other ranges of parents saying they don't want their children to get vaccinated, kind of in the 30 to 50% range, based on different sort of news articles and whatnot. So I think, again, a lot of parents may change their mind, especially if, this newest information about the success of the clinical trial down to age 12, that it's 100% effective. Some of that information might help change people's minds. And as we get more information on clinical trials from younger children as well. As we all know, the willingness to accept a vaccine really sort of falls on a continuum. We won't really go much into that because we're going to run out of time. So a couple questions that you may get as a provider, and you're starting to talk to your pediatric patients, your adolescent patients about getting the vaccine. Some people feel, was the vaccine rushed, and is the technology too new? And I just want to give you some ammunition so you can answer some of those questions. So prior to the COVID-19 vaccines, the quickest vaccine development was mumps, which took 4 years. So this is definitely very different than our current scenario, thinking about our mRNA vaccines, which took very little time. So this preclinical time usually takes years. When we're thinking about vaccine development. But this was rapidly accelerated in the COVID-19 pandemic, and there's a lot of reasons for that. So the mRNA technology is not new. mRNA was discovered, technology was discovered 30 years ago, and then it was further developed in 2002 with SARS-CoV-1 outbreak, and then with the MERS outbreak in 2012. After the first cases of COVID-19 in December 2019, the scientists in China were able to do the DNA sequencing very, very quickly. And then they published that publicly. And so they shared that information globally. So all of the scientists all over the world could sort of get to work. And quickly after that, we were able to isolate the code for the spike protein to help create the mRNA vaccines. All of this normally would have taken many, many years, but there was unprecedented funding, resource allotment, and then cooperation globally with scientists from across the world. And then our next couple of phases happened really, really quickly. And there's a couple reasons for that. Because we're in a global pandemic, the rate of disease is so high. So our scientists were able to watch to see how effective the virus was more quickly than we could for a rare disease. With something that doesn't happen as frequently, if you do a vaccine for that infection, that disease, you have to kind of sit there and wait and see if someone develops it. But if it's something that's not very common, you're going to be waiting for a really, really long time. The other thing is that people were highly motivated to participate and sign up in studies. The Pfizer study had 40,000 people originally, and then the Moderna had 30,000 people, and they were able to fill those spots and enroll people really, really quickly. So people were just highly, highly motivated to participate. And then when we think about the emergency use authorization, this is different than a full FDA approval, which typically takes a longer time because they want to look at long-term efficacy data when they decide if they should approve a vaccine or not. But because of the pandemic, the emergency use authorization moved forward and was granted while we kind of wait and collect the longer-term data. And in the interim, we've had millions of people receive some of these vaccines. Over 70 million people globally have received Pfizer. Over 70 million people globally have received Moderna, and 44,000 or more, I couldn't find a great number for that, have received the Johnson & Johnson vaccine. So a couple other questions that your parents might ask you or your patients, what's the side effect profile? Well, if we compare Moderna and Pfizer, you can see here that, a lot of times people do experience injection site pain and then sort of the percentages of what else they're experiencing. Most people are going to have increased adverse reactions after the second dose. And that's really because the first dose is priming your immune system, and the second dose, your immune system is recognizing it, and then you're going to have more of a response, hence more fever or more potential for symptoms. So in the clinical trials, they showed that the side effect profile between Moderna and Pfizer are very, very similar. I don't know your personal experience, but anecdotally, I feel like my colleagues that got Moderna versus Pfizer, Moderna after the second dose, they seem to have more symptoms, but that's just my anecdotal experience. The clinical published data shows that they're very, very similar. Over 99% of vaccine adverse reactions really do occur within the first 30 days, even the severe mediated ones. A smaller percentage, less than 1%, may occur, and if they're going to occur after that time period, it's still usually within a 2-month time period. So we've vaccinated lots and lots of people, and we're not seeing a lot of adverse reactions in what's already been described. One question people always ask, especially with the mRNA vaccines, is will the vaccine alter my DNA or my child's DNA? And I know you all already know the answer, but no. The mRNA vaccines, they do not affect or interact with DNA in any way possible. The mRNA never enters the nucleus of the cell, which is where our DNA, our genetic material, is kept. The cell breaks it down and gets rid of the mRNA like a Snapchat, right? Soon after it's finished using the instructions. Another question I've heard, some moms, dads, they might be concerned potentially about the ingredients in the vaccines. Here are the ingredients listed out. I think the notable thing here is that there's no aluminum, there's no mercury, there's no food allergens in at least the mRNA vaccines. Some people have been concerned potentially about the polyethylene glycol, and that might potentially lead to people developing allergic reactions. But the anaphylaxis I told you previously on a slide was less than 5 per 1 million for both Moderna and Pfizer. So it's like less than 0.0000005, so it's very, very unlikely. So I don't think we're going to see a huge boost in that or anything. So people can be rest assured by that. There's been some rumors floating around that the vaccines can affect sterility. So I've heard parents say that they wouldn't give the vaccine to their kids because they're worried their kids could become sterile. This comes from an article that was published in December where someone said that the mRNA vaccines could specifically target the placenta and destroy it. And so for women that receive the vaccine, they wouldn't be able to get pregnant, or it would affect their pregnancy. So one of the points in this rumor or this article is that vaccines will cause antibodies to form against placentas. And this doesn't really make sense because we're not seeing that at all in women who've had COVID-19 in their first trimester. We're not seeing increased losses compared to the baseline rate. And also the similarities between the spike protein they use for mRNA and then those in a protein in the placenta, the similarities are very little. They're very different proteins. And so biologically, it doesn't appear plausible that the mRNA vaccines would really affect the placenta at all. No one has asked this, but this is just something I was interested in. Could our schools eventually require the COVID-19 vaccine for teachers and students? So states do have the legal power to require people to get vaccinated. And if states don't require it, universities, local school districts can make that decision legally, as well as our employers. So coronavirus vaccines so far have only received emergency use authorization. So individuals truly have the option to accept or refuse it. So this sort of complicates any sort of mandates until the vaccines receive full FDA authorization. And I think at least with our local school districts, I don't think anyone's going to rush to saying that the vaccine is required anytime soon. I think that we still have our trials going on, so we still need more information. And also, requiring a vaccine for a child if there's still limited information out there, or if parents are still unsure, it could really lead to a lot of pushback and ultimately undermine vaccine efforts. That being said, I'm sure a lot of you are aware, if you have kids, that a lot of colleges and universities are requiring their students to be fully vaccinated. Just in the last week, more universities have come out with that. I know Duke, Brown, Northeastern, University of Notre Dame, Syracuse are among many others have come out and said that they really want their students and they're requiring it for them to be fully vaccinated before the first day of school. I honestly I'm for it, but I do wonder legally how they can do that because it's still under emergency use authorization. But I think in the times of a global pandemic, maybe some of that is sort of eased. And a lot of these colleges they have the expectation, people can make medical and religious exemptions, but they have the expectation that their students on campus are going to consist of mostly vaccinated individuals, and that therefore that'll sort of decrease the risk of infection for everybody who's attending. So some of you may be experiencing that right now if you have kids in college, that they need to be fully immunized before they go. And then a lot of people wonder, once we're vaccinated, can we stop wearing our mask and socially distancing? So as of right now, the CDC has really clear guidance if you're fully vaccinated. But if you're going out in public, you should still definitely have your face mask on and practice social distancing. But they have provided some recommendations for times in which you can sort of relax some of those things when you're in private settings, relax some of their recommendations about traveling. So some of you may already be providing COVID-19 vaccines to children, adolescents in your practice, but if you were interested in becoming a site, you can go to the VDH website. Our very own Danny Afula, who trained at VCU. I think everybody here knows him. He's in charge of the local Richmond Health Department. He's really stepped up and taken over the vaccine process in the state of Virginia. So they've done a really wonderful job. They've got a lot of information on there, and they have a very specific process for if your clinic is interested in providing the COVID-19 vaccine, how you can do that. And just a couple final thoughts, and we'll take some questions if there are any. I think the COVID-19 vaccine will definitely help end this pandemic for us and help us get back to a sense of normalcy. And I don't know about you, but I personally am just really looking forward to the day that our kids and our patients can spend more time with friends. They can travel with their families easily, go to school, and just enjoy their communities in a safe way and get back to some sense of normalcy. Thank you all so much for your attention. I think we have about 10 minutes for questions. So Lexi, take it away.
Thank you, Dr. Godbout. Thanks for sharing your expertise with us today. And now we're going to open the floor up for questions, Q&A. So as a reminder to our attendees, we'd love to hear from you during this time so that you can get the most out of this experience today. So please feel free to submit your questions in the chat function on the YouTube link. And we will address those. We've got about 10 minutes here for her. And actually, Dr. Godbout, I'd love to just start it off. So what are the key takeaways that you'd like for folks to I guess, have and hold today? Can you just a quick summary? Do you mind?
Yeah, of course. So I think all of the data that's coming out, at least for our kids and vaccine trials, that our Moderna and our Pfizer vaccine and hopefully our Mrna vaccine are going to be really safe and effective for kids as they are for adults. And I anticipate we're going to start vaccinating our kids as young as 12 years of age soon, and definitely before the start of the new school year. Those are kind of the main takeaway points. I do anticipate some vaccine hesitancy, but hopefully I've provided you with enough information that you can sort of have some tools to help answer some of those questions if you experience that in your clinic or with any of your patients.
Excellent. Don't be shy, folks. We're more than happy to take your questions, make sure that things are clear for you so that then you have the opportunity to share this information with your patients and families, as well as colleagues that may not be here. So I am keeping an eye up over here. Anything else you can think of, Dr. Godbout, that maybe you didn't
I think
have?
everybody,
Here we go.
Everyone's probably tired of COVID, we're.
I know, but you're bringing us some great information. Mrs. Lee Moore said, any current data on the immunocompromised patient and how effective the vaccine is?
So the not specific to children, but within the adult population, a lot of immunocompromised patients weren't included in the clinical trials, but since the vaccine has been available, there have been lots of immunocompromised adults and then kids age 16 and up that have received the vaccine and have done really, really well. And we haven't seen any serious issues in that specific population. But as far as I know, there weren't any specific, definitely not in children. There haven't been any specific trials, and there hasn't been any specific trials in adults, but we have been vaccinating immunocompromised people, and they have been doing really well with it.
Very good. Thank you so much. All right. Anything that you didn't have an opportunity to touch on or elaborate on that you'd like to add?
I think that, there's some data out there that suggested that maybe children may be more susceptible to some of the variants that we're seeing. I know a lot of that data came out, I think it was from Minnesota. They were seeing a larger outbreak in children associated with a specific variant. And I think that we just need a little bit more information before we can say, oh, wow, it's more transmissible in children. It may just be that it's more transmissible overall. And then we just happen to see an outbreak in children because I know that there was a lot of concern there for a while. But for the most part, still at VCU, we see very little children hospitalized with symptoms of COVID-19. For the most part, our kids are doing really, really well. They're managed in the ambulatory or outpatient setting. And it's just much less likely that they're going to have complications, need to be hospitalized, need oxygen. I know a lot of people worry about the multisystem inflammatory syndrome in children, which can occur after they develop an infection. We certainly see cases of that at VCU, and I also consult at St. Mary's and Chippenham, and we see those cases. But overall, they are relatively rare, and the children have done really, really well.
So I got a text question here, which is exciting. So Dr. Schneider would love to know, she's wondering if mRNA vaccines will become the new standard for future viruses, including the flu. And then what about combined vaccines?
There's some really wonderful questions. I think because of the success with mRNA vaccines that we've had with Pfizer and Moderna, I do think that we'll start to see more of that technology in the future. I can't speak specifically to the flu if that's something that they would plan to do. Actually read this article the other day about one of the women who she's a physician scientist who started working on mRNA vaccines many, many years ago. And she lost funding. A lot of people didn't respect her work. They didn't think that there was anything to mRNA vaccines. And then now we've seen how successful they are, and they are cheaper, they're easier to produce. So I think, Dr. Schneider, you're probably right on it. This is probably going to be a trend, and we probably will move towards seeing more of these vaccines. Again, we won't be able to rapidly produce them for other types of diseases or infections because it takes a long time, right? If it's not super common. Whereas right now we're in a global pandemic, and so we can get some of this work done really quickly. And I can't really speak for combination, maybe. I think we just have to see what the future holds for us.
Excellent. All right. So for breastfeeding moms who receive the vaccine, are we seeing their nursing children have side effects of the vaccine?
So in the one particular study, it was a very small N. There were, I think it was about 80 breastfeeding moms who had received the vaccine. Within the study time period, there were 4 infants who had developed fever, but each infant who had developed a fever had associated respiratory symptoms. And so they presume that those fevers were associated with kind of common childhood illnesses and not necessarily related to the vaccine. The infants within that cohort, I think the oldest infant was 8 months and the youngest infant was a couple months of age. So other than that, they didn't know anything else specific besides those fever episodes, but they didn't think that it was related to the vaccine.
Very good. And nursing mothers asking about giving breast milk to older children, effective way to get antibodies, and how long do they last and protect, and are they high enough levels?
So we know that from at least one of the studies that moms will pass on those antibodies for at least up to 6 weeks after the second dose of an mRNA vaccine. Beyond that, we just don't know because we don't have any information to suggest how long. The other thing we don't know is how effective those antibodies are. We know that they're there, but none of the studies have done neutralizing antibody studies to see how effective those are. So I'm not sure there's a lot of benefit to giving it to an older child. And if there is benefit, it's potentially short-lived.
All right. Awesome. So thus far, we're right at 2 minutes left. And I don't see any more questions. But again, Dr. Godbout, thank you so much for your presentation and sharing your expertise and information with us.
Yeah, thank you so much for having me. Y'all can always email me if you think of a question, or if I didn't address something today or you didn't want to ask it on this forum, I'd be more than happy to answer it. So thanks again. Have a great day.
Thank you. All right. Excellent. Thank you all for submitting your questions. We definitely want to make sure that you get the most out of this morning or into early afternoon today. So now we're going to keep on rocking and rolling. I have the pleasure of introducing our next speaker, Dr. Michael Martin. Dr. Martin is the current president of the Virginia chapter of the American Academy of Pediatrics. He started Einstein Pediatrics in 2016, located in Vienna, Virginia, so just north of us. Dr. Martin's clinical interests include concussion management, asthma and allergies, attention deficit disorder, and tongue ties impacting breastfeeding. Thanks so much for being with us today, Dr. Martin. And now I will hand it over to you.
Thank you. I appreciate it. And good morning, everyone. First, I'd like to thank you all for inviting us to this awesome conference. We really appreciate the opportunity to share what we're doing at the Virginia AAP chapter, and also share kind of opportunities for pediatricians out there to engage us in some of the activities that we're doing. And I mean, none of us could have predicted what happened, how this year has gone for sure. And it's been a roller coaster for all of us, and certainly for the chapter as well. So I just started in July as president. And so my agenda pretty much went out the window, as most people's plans for the year did. But I'm proud of what we've done. I'm really excited to share it with you. So amid the ongoing pandemic, we've had to deal with shortages of supplies, a public health crisis of racism, and now an escalating mental health problem in children. And like many of you, as a general pediatrician in a small practice, I am very hopeful we'll soon get back to a normal routine and get my 2 kids back to school full time. But amid all of this, I've really seen something amazing. Pediatricians finding a way to stay open and continue seeing their patients, whether in person or on telehealth, finding a way to catch up kids with vaccines and keep them vaccinated, even in parking lots, finding a way by taking on more mental health cases when psychiatrists weren't readily available to their patients. You did not waver, and that perseverance drove us at the chapter to do more and do better. So my goals for today. Pretty simple. I want to review to you what the chapter has been doing to serve you, our pediatricians, as well as what we're doing for kids in the state of Virginia. I want to identify some opportunities, ways you can get engaged in the activities that we're doing, because often we're asked and people don't know how to engage. And certainly I'm always going to encourage you to reach out to myself and my executive director, Leah Munn. There's always opportunities. And last, why are you paying that membership fee? And I want to make sure you understand and justify why you're doing that and why it's so important to be a member, not just of National AAP, but of the Virginia chapter as well. So everyone's life has been a little upended, and our story has changed from what we thought it would be. But we adapted and we learned to wear masks and sanitize our hands beyond the office and hospital settings, and even in our storybooks. At this stage, numbers are about a little over 3.5 million total cases of COVID in kids, and kids have represented nationally about 13.6% of all COVID cases. Over the last 2 weeks, there has been a 5% increase cumulative number of child COVID-19 cases, and unfortunately, kids are representing a higher proportion of new weekly cases at around 20.5%. Thankfully, children are spared the dire consequences, but they continue to be infected, symptomatic, and transmit the disease to others. With COVID vaccine positioned to receive emergency use authorization soon for children all the way down to age 12 years of age, we emerge from the winter with a little more hope and promise of a brighter summer for families and children. So in Virginia, in the early days, we mobilized quickly to support pediatricians by providing protective gear that was in short supply for far longer than it should have been to over 60 practices. And we secured free point of care testing for offices and clinics. The chapter produced 12 timely webinars and town halls to educate pediatricians on the disease, on testing protocols, on widening health disparities, and even how to get families back into the office by leveraging social media. When initial efforts to get a COVID vaccine out to providers stumbled, the chapter mobilized quickly to advocate through op-ed pieces and media interviews and communicate to community pediatricians to ensure that they were prioritized in the first wave of vaccine. The chapter's also set up 5 regional listservs that are very active even today to ensure information can be pushed out rapidly to all pediatricians, and that includes non-members, and facilitate pediatricians talking to each other, sharing experiences and ideas of how to solve the problems they're facing in their day-to-day operations. The chapter also continues to engage the Governor's Office, the Virginia Department of Health, and the Department of Education to advise and contribute to state guidance on COVID-19. And last but not least, the chapter has utilized guidance from the national AAP and advocated passionately across the state to safely reopen schools and provided needed expertise to local school systems. To that end, the chapter continues to strongly advocate that all policy considerations for school COVID-19 plans should start with the goal of having students physically present in school full time. In fact, we have advocated strongly when others did not, that schools should continue to be the first to open and the last to close in communities as disease rates have fluctuated. In the summer of 2020, we recognized the need to form a school reopening task force and received over, and this was in 3 days, if I remember, 60 applications from you, pediatricians, to serve on it. The group was tasked with the mission to promote and support the safe reopening of school systems. While we couldn't take all 60, because we've all been on these committees, you have to make sure it's a size that works. We accepted 12 AAP members on that task force, and it represents the diversity of our state by location, type of practice, and very importantly, even race. The group is also has representation from school nursing and regularly invites representatives from the state's Department of Health as well as the Department of Education. It has produced 5 town halls on COVID-related issues regarding prevention strategies in schools, masking, athletics, and updated metrics and evidence. The group provided assistance to the state health department in writing its own recommendations for schools, as well as providing valuable guidance to the governor's office in its own priorities and public announcements. Members have sat on committees at the state representing the interests of children and pediatricians with relation to access to PPE and COVID testing, vaccination efforts and communications, and most recently, COVID testing and screening strategies that will likely begin at schools in the fall. The members of this task force have been the face of the AAP at school board meetings and town halls in almost every school district across our state, and have provided an educational video most recently for school staff and parents as schools recently reopened. So to get to Emily's point, vaccination is going to play a huge role in school safety, as 3 feet is really not achievable for social distancing for all students to come back to school full time in the fall. Now, Pfizer is poised to receive EAU use for children down to 12, and Mrna is likely to follow behind this. And this is really going to make a huge difference in terms of achieving those goals for the fall and helping schools as they make their plans. And while mass vaccination sites, including schools, are in the plans and will play an important role in immunizing kids, we have to realize that there is no substitute for the trusted pediatric medical home to accomplish our mission of vaccinating all kids. In the coming weeks, and actually you hopefully have all received notifications and requests, practices and offices are going to need to make a decision as to whether they will or will not be giving the COVID vaccine. And with so much confusion, misinformation, and frankly, vaccine hesitancy that was there before, many families will want to get the vaccine in a place and by people they know and trust. And this has been shown over and over in surveys of adults. Their first and foremost, most trusted site is their own doctor. And we know that many of you will step up to this challenge, and the chapter will be here to support you. In the years since the issuance of the COVID-19 emergency declaration, our patients have experienced a major disruption in their lives, including disruptions to academic structure, participation in activities, peer interactions, lifestyle, and their overall physical and emotional health. To better identify and address the concerns of our patients and providers in Virginia, the chapter conducted a survey in December 2020 with over 200 pediatric providers in Virginia responding. The responding pediatric providers were seeing and continue to see an alarming decline in mental, behavioral, academic, and general health of their patients. 98% reported an increase in child and adolescent anxiety. 95% reported an increase in depression. And even more concerning was an increase in suicidal ideation in children and adolescents, and about 58% of providers reporting that increase. And I have to say, even in my own practice, which, we have 4 providers, we haven't been immune to that phenomena. We were admitting at one point more in a week than I would have admitted in over 6 months to the hospital for emotional and behavioral problems, to the emergency room. The data has been used to raise the alarms to the public through media interviews, presentations to school superintendents and school boards, and at public town halls. And thanks to the participation of pediatricians in Virginia in these surveys, our chapter was able to advocate on behalf of kids using data specific to our state, highlighting the robust increases in mental and emotional health problems. And because of this, we were able to secure funding for the expansion of the much needed Virginia Mental Health Access Program, or what you probably more affectionately know as VMAP. VMAP serves to educate primary care providers through REACH and ECHO programs throughout the state. It hosts a call center for primary care providers in need of advice from either a psychiatrist or psychologist regarding the care of one of their patients, or if a provider and family need help with navigation and connecting their patient with the right mental health provider at the right time. Now, you're going to be hearing about this program later, but I want you to know that this program really took off under the leadership of Dr. Sandy Chung, and we were able to elevate this small program into a statewide program in a matter of just a few years. The chapter has also found a lot of success on the front of immunizations. Hopefully you've received word that HB 1090 takes effect in July and expands requirements for immunizations for school attendance. It also serves to expand VFC coverage to vaccines on the ACIP schedule that weren't there before, and it ensures that the Virginia Code stays current with changes that the ACIP publishes in its schedule. And this is actually important because one of the challenges we've had is that every time there was a change in that schedule, we would have to go to the General Assembly to have them approve those changes. Under this new bill, we'll be able to do that without getting approval, that the changes will be updated as the ACIP does. And it still allows for the legislator to step in if it doesn't agree with something, but it's always been an uphill battle of getting the legislator to make those changes because of a strong anti-vaccine voice, even though it's a very small number of people against. This past January, at the request of the chapter, Delegate Willett introduced a bill, HB 2061, which since has been signed by the governor. And what it does, it requires any and all healthcare providers in the state of Virginia who give vaccines must participate in the Virginia Immunization Information System, or VIS, and report that history into the system. And so as the chapter and the Department of Health work to address vaccine hesitancy and now larger gaps that we're seeing as children have fallen further behind in their vaccine schedules, we'll be able to address those larger gaps and have a more robust and complete data set upon which to base our interventions. And last but not least, we recently received an AAP grant for an immunization project funded by the CDC to increase the vaccination uptake in our patients. On another bright note in the vaccine front, this year also marks the first anniversary of our state's immunization coalition, Immunize VA, whose steering committee is led by 3 of your own Virginia AAP members, which include myself. So I've mentioned some of the legislative successes we had on the immunization front, but we have a lot of other things that are on our agenda that are far more ambitious than just immunizations. We now use voter voice to coordinate our efforts to reach our members and mobilize them to reach out to legislators when advocating for children. Our Pediatric General Assembly Day, probably what most people know is our White Coat Day, it's our more affectionate name for it, is one of our most successful annual events where members can engage on the issues and meet their legislator. Now, COVID definitely changed the dynamic this year, but I'm really, really proud of what we were able to put together virtually with over 80 people attending still this year virtually. And I have to tell you, this year had actually in many ways was one of the most successful legislative sessions we've had in pediatrics. From the VIS bill I've already mentioned, to finding both a senator and delegate to carry a budget amendment to require a study of healthcare options for undocumented children. We didn't just take position on bills, which is generally what mostly we've done in the past. We actually started to help write bills. Now, immigration has become a big issue in our country, and our Child Immigrant Health Committee recently engaged in a number of collaborative initiatives, including the budget amendment I just mentioned. The chapter collaborated on an educational series with the Inova Children's Hospital's residency advocacy program to teach trainees about the factors that impact the health of immigrant children. Topics included global health, medical relief at the border, grassroots level physician advocacy, mental health needs of immigrant youth, and a discussion on the legal issues surrounding unaccompanied minors and migrant children. We also collaborated, and we've done this in the past on a number of other issues too. We've collaborated with the DC chapter's Global Health Symposium for Providers. And finally, as part of our continued efforts to expand access to care, the Virginia AAP joined the Specialty Care Access Network, or SCAN, a national network of physicians which helps facilitate transition of care needs for migrant children with subspecialty needs. As COVID has really laid bare the importance of screening for early childhood problems, the chapter through the ASHU grant has been diligently working to improve outpatient screening for ACEs, postpartum depression, social determinants of health, and social emotional changes. The grant began in August 2020 and runs through this year. And we have heard from various expert speakers in the country regarding why and how to best screen, as well as what to do with those positive results. We are learning about how to deliver care through an equity lens and how to look for protective factors. And I have very exciting news on this front. If you were not able to be part of the ASHU grant, we have another opportunity coming up in June. So we have a QI project that's starting in June. I've put the link there, but if you go to our website at virginiapediatrics.org, you'll find it. It's a QI project that's going to help you identify social determinants of health. And the most important part of this, it's not just identifying, but helping you figure out how to intervene. And that's been a part of the ASHU grant. I think one of the complaints of some of these projects, or one of the limitations, was once you identify someone, what's the next step? What can you do? And so that is a main focus of both this QI project as well as the ASHU grant. And on that front as well, we actually will be rolling out a new online platform for our members at the AAP chapter to help connect them and their patients with local resources and services. For those who aren't familiar, we're using a platform called Aunt Bertha, and I hope in the coming months, I'll be able to announce that going online and being available to you. And really, it's going to help you connect, whether it's mental health, behavioral health, food insecurity, resources in your region. Now, there remain significant disparities based on race, ethnicity, and socioeconomic status for virtually every child health measure in our state. And the bad news is COVID has only made it worse. Achieving health equity has long been a goal of the Academy, but we're taking a bigger role in owning it and addressing it at the chapter level. And I'm proud of our efforts to improve the care of minority and disadvantaged children and of our tireless advocacy on behalf of those whose obstacles are the greatest. We have 2 individuals at our chapter who specifically are focused on these issues and ensure that equity is considered in all of our committee's work, as well as our board and the specific projects. We're actually getting involved in juvenile justice reform as well. And we have a catch grant that's addressing racial and culturally specific trauma-informed care for kids going on now. Now, I'd be remiss, so a lot of these things I've talked about really have to do advocating for kids, but we are also really working hard to advocate for you as pediatricians. And so I want to remind people that we do have a chapter pediatric council. And this is primarily for, it's not just for those in practice. I will say a lot of the issues where pediatricians don't have support is in the outpatient setting, but it's not limited to that. We are advocating even for hospital-based issues that come up with payment. And so the council is really designed to help you when you're running into insurance company problems about getting codes paid for, never happens, right? Getting prior authorizations, whether it's Medicaid issues or private insurers. We actually have two co-chairs, both by the name of Suzanne Powers and Suzanne Brixey, who are really dedicated to working on these issues. We do recommend that you, at the national level, we still using the Hasselbeck complaints, where you actually put in what the issue you're running into, so that at the national, and they push those down to the state level, that you put those in there so that we have a database of problems. So when we see patterns where multiple providers are running into the issues, we have the data when we go and work with the insurers on it. So that's still important that you have that complaint form filled out, and we'll direct you to that. But we're also want to hear directly from you. And I know both Suzannes have been really receptive to that. So I'm going to encourage you to use this. I don't think people are always aware at the chapter level that we have that, but it's there for you. And you can contact us both directly through our executive director and through myself. And we've had success with this. I have to say, we've had improvements in COVID testing, as well as we've worked on actually the administration fees for COVID, and we have had success in improving the payments for both of those things. So unfortunately, national data has shed new light on how the COVID-19 pandemic is affecting medical providers, and pediatricians really aren't immune to the mental health effects. For frontline hospital workers, it's often the visceral jolt and exhausting work of caring for critically ill patients. But even general pediatricians in the outpatient, we've had the fear of being infected ourselves, bringing home the infection as we continue to test and see these patients. And in Virginia, we've had 26,000 healthcare providers that have been infected. And there's stress that comes with that. And then there's been a radical shift even in our day-to-day operations that really has affected all of us. And so the chapter under the leadership of Dr. Riva Kamat has formed its own physician wellness committee, which meets bi-monthly to address these challenges. The committee is in the process of a needs assessment and survey at the moment, but their goal is really to develop a repository of high quality resources for physician wellness and to identify personal and system factors to support the well-being of pediatric providers throughout the state, as well as the factors that contribute to provider burnout. And so that's going to be coming on much more active this year, and I'm really excited about the work that Riva is doing on that. All right, so here comes the part of the ask. I was going to have to ask you to do something. It's not all what we're doing. We need your help. So first and foremost, if you're not already a member, please join the chapter. If you are a national member, understand that does not mean you are a member of the state chapter. You actually have to check a box that says that you want to be a chapter member when you're signing up for national. And I have to tell you, we have, in Virginia, for national AP, we only have about 65 to 70% of national AP members in Virginia are actually chapter members. So we have a long ways to go to get closer to having that 100%. All right, so if you are a chapter member, my ask to you is join a committee, engage in some of the other initiatives that we contact you about. So one of the things, if you haven't joined the listserv, reach out to us, we'll put you on those. But once you are a member as well, you will be receiving updates and emails weekly about learning opportunities, as well as what's going on at the chapter. There's going to be, I'm constantly pushing out opportunities for people to engage. Right now, we're actually recruiting for a focus group on that grant that I told you about in terms of immunization and really trying to lift our percentage of kids that are vaccinated in our state. One of the lightest lifts is really our Pediatric General Assembly Day. Or White Coat Day, as most people know it. It's an opportunity for you to advocate on the bills locally with your legislator, and it's so important that the legislators, and it's your legislator that you're reaching out to. So it's helpful for me as chapter president to reach out, and for the leadership to reach out to all legislators. But the reality is you're their voting constituency, and so they really want to hear from you, and they're much more likely to move to action hearing from those who vote for them. Another is part of our successful advocacy has really been our political action committee. And we need donations for this. And this is, I'm going to admit, this is old data, but I have to tell you, we still fall at the bottom of all the specialties in terms of how much we receive in donations. And I think it's really just a testament of our raw, advocacy, like grassroots work, that we've been as successful as we are. But if we can increase these funds, I can promise you, we will actually have more meetings with legislators and we'll have more success. And even if, each of our members only donated $5 to $10, this would make a huge difference. And you can donate on our website. I've left the website up there. It's a really small, it doesn't have to be big amounts, but anything makes a big difference if everyone contributes. And I have to say, this is an exciting moment. I think things are turning. A lot of that is due to the work that you all are doing in the field. And now we really do have a lot more knowledge, materials, and resources to help our communities emerge on the other side of this pandemic. And I really look forward to working with all of you to protect our patients and keep our communities safe and get kids back to school. So I just want to say thank you for everything that you all are doing on behalf of kids and putting yourselves at times at risk. It hasn't gone for nothing. And at the chapter, we really do appreciate everything you do every day. Thank you.
Thank you so much, Dr. Martin, for joining us this morning and sharing your insight. And participants, we have time for a Q&A. So just don't forget, please, if you have any questions for any of our speakers, use the chat function in the YouTube link on the right side of your screen. So thanks again, Dr. Martin. We appreciate your time and the update and sharing and encouraging folks to join in and continue to support the AAP and all of the good work that our community does.
Thank you.
All right. I'm going to have a little pause here and just see if anybody's got any questions that pop up. And if not, we've now approached our first 10-minute break here. So feel free to stretch your legs, refill your coffee this morning, grab a snack, and we'll return for another presentation by Dr. Ledin Dalavato Gahar, which will begin at 9:20 this morning. So let me see, I guess that gives us actually about 14 minutes for our break. Every minute counts today, folks, every minute counts. So I guess with that, we'll go ahead and you'll have a couple of extra minutes.
Thanks, everyone.
Thanks, Dr. Martin. Welcome back, everyone. We hope you had a nice break, and we are now being joined by Dr. Davallo, who will discuss disorders of puberty. Dr. Davallo is an assistant professor of pediatrics at VCU, specializing in pediatric endocrinology with a focus in growth, thyroid disorders, and diabetes in children. In addition, Dr. Davallo is a member of the Pediatric Endocrine Society and the Endocrine Society. Dr. Davallo, we are so glad you could join us today. And now I will turn it over to you.
Thank you for having me. And thanks everyone for joining. So I'll be discussing disorders of puberty. To start, I have nothing to disclose. And we're going to be doing some questions. So with poll everywhere, and then you can see the link right below here. Oops. Let me just show that screen. So pollev.com/LadanD180. And if you can pull that up, usually the best way to do it is on your cell phone, and then answer this question. So the first question is, what is the first sign of puberty in a boy? So we'll give you a few seconds to, and I'll bring up the question here as well. And we'll make this full screen right up here. So what is the first sign of puberty in a boy? We'll give you a few seconds to do that. I'm going to actually show the responses to see if we've gotten some responses here. All right, so we have 50% axillary hair, 50% testicular enlargement. And I know that there's a little bit of a lag getting the answers in, so I'll give you a couple of seconds and we can go back. Okay. So just have this here. So the answer is testicular enlargement. So that's great. Half got it right. So before we start into like discussing female and male puberty, we'll discuss what is puberty. So it's defined by secondary sexual characteristics and reproductive function. It's a lot of terms go under puberty, including thelarchy, menarche, spermarchy, adrenarchy, pubarchy. So I'm sure everyone has heard all these terms, and we'll be discussing each in more detail. And biochemically, puberty is defined by an LH of greater than 0.3 for central puberty. And FSH range is a little bit more variable. And when you talk about puberty, it's really the activation of the hypothalamic pituitary gonadal axis. And here we have the hypothalamus, the pituitary, and then the gonads. And the trigger, what triggers this is really largely unknown. But we do know that you need pulsatile secretion of Gnrh to activate FSH and LH in the pituitary. And then LH is involved with the production of sex steroids, which are estradiol and testosterone. And FSH is involved with the maturation of the gametes, the egg and the sperm. And this is a closed loop feedback. And this is really important when you're trying to determine the differences between peripheral precocious puberty and central. So we'll talk a little bit about that in the future, but if you have a lot of estrogen or if you have a lot of testosterone, that will feed back to the LH and FSH and shut it down. So that's important for later. We look at puberty with Tanner stages, or also known as sexual maturity rating. And you can see that here there is a maturation stage for pubic hair, but also for breast tissue. And I really like to focus on the extremes. So you know that 1, there is nothing, no signs of puberty, and 5 is an adult sort of exam. And then in between, we won't go into details, but you can kind of look at this reference to see what stage a child is in puberty. What I wanted to note that inspection is not enough for the breast tissue, because when you inspect the breast in someone who is obese, then you can't really tell between adipose tissue and breast tissue. And so it's really important to also palpate, and glandular tissue is a little bit more dense than adipose tissue. So in terms of female pubertal development, onsets usually age 8 to 12, average around 10. And you can see that there is racial differences in terms of the average onset of thelarchy. Thelarchy is actually the first sign of puberty in a female. And you can see African-American girls tend to start puberty a little bit earlier, on average 1 year, than non-Hispanic whites. And you can see Hispanics, the onset of thelarchy is a little bit earlier, and then non-Hispanic white and Asian around 9.7. And then we have physiologic leukochoria. And then after that, 2 years on average after the start of thelarchy is menarche, the start of the menstrual cycle. And this is sort of, you have the anovulatory cycles in the beginning, and this is important because females, or adolescent girls, can have irregular periods in the beginning, and that could be normal. In terms of male pubertal development, the range is between 9 and 14, mean is around 11 and a half. And both for females and males, there's some data that suggests earlier onsets. And the first sign is testicular enlargement, and then that is followed by increased penile length. So testicular enlargement, if you want to take away one thing about male pubertal development, is that's the first sign of puberty. And when we look at the exam, a testicular volume of greater than 3 mLs or a length that's greater than 2.5 is considered the onset of puberty. It's greater than 3 mLs, but it's usually closer to 4. And then adrenarchy follows, and sometimes it's even before the start of true puberty, and we will talk about that later. And when the testicular growth happens, then there's testosterone production, and this leads to facial hair development, voice deepening, and increased muscle mass, and all the secondary sex characteristics that you see. This is also important to note that gynecomastia, or adipose tissue in the male breast, it occurs in 50% of males during puberty. So it's very, very, very common. And we'll talk a little bit about that later as well. So I wanted to highlight the sporkidometer, or the beads that we use to measure or to have a reference for testicular volume. You can order it online. We all as endocrinologists have some, and we use it as references. You can see here, you can see the darker blue colors are pre-pubertal testes. And then this color is really from 4 and up is the start of puberty. And I know that I said 3, but sometimes puberty starts happening at 3 mL. So you can say 3 to 4 mLs is the start of puberty. In terms of the timeline, here you can see the age and then the growth velocity. So you can see that around 11 and a half is when you see the first sign of puberty on average, increase in testicular volume. And then pubic hair can happen before or after, but generally after. And then the peak height velocity for boys happens right at around age 13 and a half. And then you can see all the other signs of puberty after that. For a girl, breast development starts right about age 10, maybe a little bit earlier. And then you can see peak height velocity happens at around this age, so 11 and a half, maybe a little bit earlier. And then menarche average age is around 12. And then you can see completion of puberty. Usually females, they stop growing around age 15, and this is a bone age of 15. And for males, they stop growing at a bone age of 17. This is another way to look at growth. So here it breaks it down into the pubertal onset. So if you're early bloomer, it's in blue, and then average is in black, and late bloomer is in pink. So here you could see, and these are females and males. So in females, you can see that the peak height velocity is less than males. And for both females and males, the earlier onset puberty, they do tend to grow fast, and they stop growing quicker than late onset. So late onset puberty, it tends to last longer, and it's really this lasting longer that actually tends to increase their adult heights or give them higher height potential. So this is SMR or Tanner stage 2 to 3. That's when girls have their growth spurt, but in boys, it's a little later, so 3 to 4. And this, because females have this lower peak height velocity and tend to go and to have it earlier, then they have a little bit less peak height velocity than in boys. And there are lots of factors that affect the timing of puberty. And we have heard about endocrine disrupting chemicals in the media. And also the AAP released a statement in 2018 telling parents basically that there could be a potential harm to using plastics and putting plastics in the microwave, in the dishwasher. And there's a potential link to either earlier or later onset puberty, but mostly earlier. And then there are birth characteristics that affect the timing of puberty, including being IUGR, intrauterine growth restriction, and small for gestational age. And we know that nutritional status has a lot of effect on the timing of puberty. So obesity tends to have earlier onset. So patients with obesity tend to have earlier onset puberty. And then undernutrition tends to lead to later onset. And we know about the female triad, so women who have eating disorder with menstrual disturbance and osteoporosis. And those girls tend to have lower body fat stores, which has, and leptin is a hormone that is secreted by the adipose tissue. And having lower leptin actually is found to have a link to gonadotropin deficiency. And then chronic illness also affects the timing of puberty. Generally, chronic illness such as diabetes, rheumatoid arthritis, cystic fibrosis, sickle cell disease. So all of those can affect the timing of puberty, generally late puberty. Wanted to talk a little bit about adrenarchy. So adrenarchy is defined by increased adrenal androgen production. So the adrenal gland makes hormones, mainly DHEAS. And there's a reason why they call it DHEAS, because the actual name is really, really long, dihydroepiandrosterone sulfate. So this hormone is involved with a lot of the signs that we generally associate with the onset of puberty, which are actually a separate thing, a separate entity. So puberty, like we discussed before, is the start of the trigger of the gonadal hypothalamic pituitary gonadal axis, so the central puberty. Adrenarchy is increased in adrenal hormones, and it's independent of that HPG axis. So the adrenal gland is involved, again, with the production of the DHEAS in children and women, 90% of that, and then 70% in adult men. And then 50%, it's also involved with the production of 50% of testosterone in women and less than 10% in male. So let's switch gears to abnormal puberty. And we're gonna do this very much case-based. So the first case is, and I want you to pay attention because there's going to be a question after this. We're going to go to the poll everywhere. So this is a 6-year-old boy who presents with evaluation of precocious puberty. So this is his chief complaint. Mom noted pubic hair and mild body odor 3 months prior to the visit. On exam, you find that he has Tanner 2 or SMR2 pubic hair, and his testes is 2 mLs bilaterally. And I've included his growth chart, so generally pretty normal growth velocity and waking. Labs were done, and these are adrenal hormones, the first sort of 4, and then we have LH as well. So labs were all normal. His bone age, so we did a bone age, and we'll talk about bone age a little bit later, but it basically, what I tell patients about bone age is an x-ray of the left hand that tells you how old the body thinks it is. And his bone age was pretty much consistent with chronological age. So the question for everyone is that what is the most likely diagnosis? So again, you can access the poll with pollev.com/Ladan D180. And then this, just a sec, the question, I have to activate it. So let me do that first. So let me see next. Oh, yay, I see that the previous question, most people got testicular enlargement. So let me activate this question and show responses. Okay, and then like full screen for you. Okay, so everyone's looking 33%. So we see, okay. Give it a second here. 50-50. We have a 50-50 audience. Okay, so it's pretty much, people think it's between premature adrenarchy and idiopathic central precocious puberty. So let's get out of here and I'll discuss the answer. All right. So the answer is premature adrenarchy. So this child had a chief complaint of puberty, however, was found to have Tanner 2 testicular, so Tanner 2 pubic hair, and also the testicles were 2 ml. So actually that's pre-pubertal. So we discussed that puberty is defined by a testes that is greater than 4 ml. So 4 mLs or greater. So this is actually premature adrenarchy, and the child had normal growth as well. So we'll talk about premature adrenarchy. This is a slight increase in that hormone, the adrenal hormone we talked about, DHEAS. And the age where it's premature is less than 8 years in girls and less than 9 years in boys. And with this adrenal hormone, you have this pubic hair, axillary hair, body odor, mild acne, and a slightly advanced bone age. So the bone age could be equivalent to the age of the child, or it could be slightly advanced. And the child may or may not be taller than expected because of that slight advanced bone age. And if the growth is normal and everything and the tempo, okay, by tempo, I mean the progression of the symptoms. So if you have pubic hair onset, you know, in month 1, and then you have like within 1 or 2 months, you go from Tanner 2 to Tanner 5, that's very concerning. So that's too accelerated. But if it is progressing, so it will progress, but at a slower rate, if that's okay, then we just follow these patients. We don't do anything else. However, accelerated growth, rapid progression of symptoms, and if there's virilizing signs such as clitoromegaly and then increased penile growth, then this is a little bit more concerning. And what I'm concerned about is other sources of androgens, such as you know, tumors and non-classic CAH. So there's other causes that can cause this. It is benign, but there is an increased risk of PCOS or polycystic ovarian syndrome and metabolic disorder later in life if someone does have premature adrenarchy. So this is bone age, and that's what we discussed, that if you are concerned about a patient with premature adrenarchy, the first thing to get is a bone age. So again, it shows you how old the body thinks it is by looking at growth plates here. And then we use a reference book to see how old that bone age looks compared to that reference, and then compare that to the chronological age of the child. You can also get adrenal labs, and adrenal labs include the DHEAS that we talked about. 17-OHP is mostly to rule out non-classic CAH, and CAH, just as a review, the most common cause is a 21 hydroxylase deficiency. So it's an enzyme in the adrenal gland. And it's in the sort of pathway to production of steroids, cortisol, and mineralocorticoids as well. And then so if you have an elevated 17-OHP, then this is concerning for non-classic CAH. Androstenedione is another adrenal hormone, and it just gives us a little bit more information about what the adrenal hormones are doing if they're elevated. Depends on the degree of elevation. So if DHEAS is in the hundreds, and I would say I would start becoming concerned if it's greater than 400, then it would start to like make you think about adrenal tumor as one of the causes of the sort of the signs and symptoms that they're having, versus if it's below 400, especially if it's okay for their Tanner stage, then you would be less concerned. Testosterone is also important because if you have a very, very high testosterone level, but a normal DHEAS, then you might be concerned about a testicular tumor that's secreting testosterone. I wanted to add on this entity called benign pubic hair of infancy. And so this is where there's a little bit of pubic hair, usually on the labia and scrotum in an infant. And usually it's not, you can see here, there's just a little few hairs. It's usually not the thick pubic hair that you see with puberty. And this is actually benign, and it usually self-resolves. And if there's no genital enlargement, there's normal growth, and it's not rapidly increasing, then you're more reassured. And it usually goes away by age 1. So case number 2, again, there's going to be a question. So you have a 2-year-old female that presents with breast development and vaginal discharge. And on exam was noted to have Tanner 2 breasts, Tanner 2 pubic hair, pink vaginal mucosa, and no cafe au lait spots. So you got an evaluation, and the LH was 0.1, FSH less than 0.2, estradiol was elevated at 108.6. So think about the axis and what you're kind of looking at here. We did a Gnrh stim test, and for those of you who don't know what this is, it is the gold standard for diagnosing puberty. And we look at the LH and FSH response, and then if there's an LH of greater than usually 5, then that's consistent with the start of puberty. But this child had a pre-pubertal response. And transabdominal ultrasound was done, and there's no ovarian tumor cyst, but the uterine side was actually post-pubertal. A bone age was done at chronological age of 2-year, 10-month, and was read as 3-year, 10 months, so it was advanced. A skeletal survey was done and showed no fibrous dysplasia, and this is generally done to rule out McCune-Albright syndrome, which can present like this child. Tumor markers were negative, and MRI abdomen was normal. What is the most likely diagnosis? So let me go back here again. Just give me a second. I'm going to activate the next question. So activate, show responses, full screen. All right. What is the most likely diagnosis? Okay, so maybe it's on my end. It's not activating. Okay, I'm starting to get some answers here, so that's good. Okay, so I see some B, some C. I'll get a few seconds. All right, so majority feel like it's exogenous estrogen exposure. So let's see. Oh, don't know why it went backwards. So let me just pull this up, sorry. Okay, the answer is exogenous estrogen exposure. So we have a smart audience here. So I'll talk a little bit about that case later, but I wanna just give you an overview of precocious puberty. So precocious puberty is the signs of puberty that we talked about in age less than 8 in girls and less than 9 in boys. And it could be characterized as central versus precocious. And central precocious puberty is generally idiopathic. That means there's no structural cause or something that you can actually see in 90% of girls and in 50% of boys. So this is important because if we see signs of puberty in a boy that's early, we're more likely to be worried because it's not idiopathic and it's more pathologic in boys. So that's why we're more likely to be worried, and we're more likely. So any boy that has central precocious puberty, which we tend to work them up, and by that I mean with an MRI. So again, central versus peripheral precocious puberty. And then this just lists the cost. So in general, mostly idiopathic, means, it just happens. And then there's some central causes. And then in peripheral precocious puberty, some of the things we don't have time to go into details, but generally what we see is an ovarian cyst, ovarian tumor. Then there's also McCune-Albright syndrome, and then something called familial testotoxicosis, which basically means that the testes is producing, it's an activating mutation of LH receptor. And then we have normal variants of puberty, including premature thelarchy and premature adrenarchy. How do you evaluate precocious puberty? So we tend to do an early morning, high sensitivity LH. And I say early morning just because we tend to see higher pulses in the morning, and we tend to want to catch the pulses. We see them better in the morning. And then high sensitivity so that we can see very minute changes in the LH, because like I mentioned, an LH of greater than 0.3 is considered consistent with the start of central puberty. And then FSH, we also get an FSH and an estradiol level for a girl, testosterone level for a boy. So history and physical exam direct other labs. So if you're concerned about other things, and I do tend to check thyroid as well, because I have seen very poorly controlled or very severe onset of hypothyroidism that presents with precocious puberty. We do adrenal labs, especially if there's a lot of pubic hair, axillary hair, and signs of premature adrenarchy. And then tumor markers is generally not my first line, but if I was concerned about a quick tempo of symptoms, then I would get tumor markers as well. We sometimes do get pelvic ultrasound, especially if there's isolated vaginal bleeding. And then I talked about this a little bit previously, but that stimulation test that we do is pretty much gold standard. So we do screening labs, but then if it's concerning, then we will do a stimulation test. Wanted to give you a little bit of a look into a benign entity. And so this is not puberty. So this is something else, premature thelarchy. So this is benign. It's isolated breast development. So just no other symptoms, no other, there's no pubic hair, there's no axillary hair, there's no linear growth acceleration. So these children have normal growth. And it's generally in children that are less than 2 years of age. If the child is greater than 2 years, then you're generally more concerned that this could either progress to puberty or it just won't go away. And the cause is largely unknown, but there's some sensitivity to estrogen. And some people think it's because of ovarian cysts happening, and then they burst, and then they release some estrogen. And this is for your reference, just showing you the difference between actual puberty and premature thelarchy. So the case that we looked at was a 2-year-old girl. She had breast development, and her workup was notable for high estrogen, low gonadotropins. Gonadotropins are LH and FSH, and ultrasound showing a post-pubertal, a pubertal sized uterus. So this, let me just talk a little bit about this. So we know that the high estrogen level, low gonadotropins is consistent with peripheral precocious puberty, right? Because if it was central precocious puberty, then the gonadotropins LH and FSH would be elevated, and that would lead to a high estrogen level. But here we have a high estrogen level leading to a low LH and FSH. And then we know that because of these labs, and also because the ultrasound actually showed a post-pubertal size uterus, we know that this is not just premature adrenarchy. And so the best answer was the sort of, what was I going to say? The best answer was the exogenous estradiol. So this child was, upon follow-up, parents actually revealed that the grandmother uses vaginal estrogen cream. And this was the source of the exogenous estrogen. And the child was with the grandmother for a while, for a short period of time. And then once she was taken out of the care of the grandmother, symptoms just kind of resolved on their own, and then the estradiol came down. And so you can see that this like topical transmission of exogenous estrogen could be so profound. And I've also seen this in males where grandpa or someone else in the family is on testosterone cream. If someone is on testosterone cream or any topical gel, there's always a risk of transmission to the child. And so I tend to always ask about that, even if they say, oh yeah, we keep it away, because if you just live with that family member, you give them hugs, you have the same laundry, you're gonna have some transmission. And so follow-up clinic, the estradiol was normal, this child's breast buds decreased in size, and there was complete resolution of symptoms after removal of exposure. All right, so case number 3. So there's going to be a question after this as well. This is a 9-year-old African-American female who presents with first menstrual cycle. So this child had breast development, pubic hair that started at the age of 7 years. She had no neurologic symptoms. She did have an elevated BMI, but otherwise was doing well, and she was pretty much coping well with this. Her exam showed Tanner 5 breasts and pubic hair, and then she did have acanthosis of the neck area. This is her growth chart. So you can see that she has had an accelerated growth, and she's very tall, and accelerated weight gain as well. She had an LH of 2.3, an FSH of 5, estradiol 88, and her bone age was actually advanced by 3 years. You can see a star here. So in Ped Endo, we like to plot the bone age. So what we do is whenever the child got the bone age, so at this age, at this point of time, we then plot what the bone age was. So the child was almost 10, the bone age would be almost 13. And then we can see, based on the bone age, whether the child has a predicted height that is normal. So you can see that if the child is right here, it's pretty much along the 75th percentile. And so this is a normal height. So would you treat this patient? And there's no right answer here, but I just want to see what you all, if you were a pediatric endocrinologist, what you would do. A couple of seconds. All right, so I have around 70% no and 29% yes. So let's see. All right. So let's, maybe I have 2 here. Okay. Bring this up. So I actually would not treat this patient. And again, you can ask another endocrinologist and they may choose to treat this patient. The questions that I ask myself, whether to treat a patient or not for precocious puberty, is why. So firstly, why do we treat? We treat because, firstly, if we're trying to preserve adult height, we looked at the graphs before and we saw that if you have puberty that's earlier, you tend to have a lower near adult height. And so, preserving adult height, that's one reason to treat. The other is psychosocial concerns. So I have families that come to me and they're like, well, my 8 or 9-year-old, she's already started her periods and she's just not ready. And so you can C, maybe that's a reason to treat, but also normalization of female physiology is also important. So if we think that through therapy or through some other way that we can normalize this, then maybe perhaps treatment is not needed. And we do treat with what are called Gnrh analogs. So we talked a little bit about this before, that when you look at the HPG axis, the hypothalamic pituitary gonadal axis, you see that the pulsatile GnRH in the hypothalamus is needed to start puberty. However, if there's a constant source of GnRH, which all of these things that I listed here are, then that tends to stop puberty. So it could be a monthly injection, it could be a 3-month injection, and these are intramuscular, so they are painful. It could be, and there's newer formulations out there that are every 6 months. And then we have implants. So you put the implant in there. Generally, it's supposed to be approved for 1 year, but we've seen, and there have been studies showing that it is helpful, and it works up to 2 years. So sometimes we take it out at the 2-year time frame. All right, so case number 3. So there is a question after this as well. Oh wait, this is just before, actually we're on case number 4. So this is just the same patient that we talked about before. So her adult height was normal, like I mentioned here, and she was not in distress. So that's why we don't treat. So case number 4. This is a 14-and-a-half-year-old otherwise healthy male who presents for late puberty. His past medical history is notable for undescended testes as an infant, status post-repair. He's active, he has a normal sense of smell, his review system is otherwise negative. His mom's 5'6", dad's 5'9", so his mid-parental height is 5'10". And then his growth is pretty normal and his BMI is normal. And then on exam, he has 2 mLs testes bilaterally. He has no gynecomastia, and he's otherwise, everything else is normal. So workup was all within normal limits, including CBC, CMP, growth factors such as IGF-1, IGF-BP3, thyroid function tests, ESR, inflammatory screen, and celiac screen. And his LH gonadotropins was 0.1, so is prepubertal. LH is 0.3, FSH is 0.3, testosterone is 8, so low. His bone age was done at a chronological age, so actual age of 14.5, and bone age was read as 13.5, so slightly delayed, not too delayed. So what is the diagnosis? So you can go on the poll, and I'm gonna activate it here. This is a little bit more tricky, so, but we'll go through this and discuss it. So we have C, constitutional delay. We have E, which is either constitutional delay of growth in puberty or hypogonadism. So shifting towards E. Right, well, this audience is super smart. So the answer is C or D. So you have a 14-year-old male who has late puberty, and you don't know at that time if he has constitutional delay. Is this a delay in puberty, or is this hypogonadism? And really the answer is we don't know, because the lab work is going to be the same and the exam is pretty much the same. So how do you differentiate? You'll find out. So delayed puberty is basically having no breasts by 13 years, or amenorrhea by 15 to 16 years for a girl, and no testicular growth by age 14 in a boy. So you want to do an initial screen by asking about nutrition, exercise, illness, medications. You want to ask about their health. And if you have midline defect, which I mean any defect kind of in the middle of the body, and sometimes that could be dysmorphic features, umbilical hernia, other things as well. And neurologic symptoms make you a little bit more concerned for a central cause. Anosmia or inability to smell is very interesting because one of the differential is Clotting Syndrome, which is an inability to smell, but also with hypogonadism. And you don't ask the child, can you smell? You actually ask them, if mom or dad make coffee in the morning, are you able to sense that? So you ask very, very specific questions, or can you smell flowers when you smell it? So it has to be very specific questions. And so there's usually a family history of constitutional delay of growth and puberty, also known as late bloomer. And if you're looking at the differential, we differentiate between primary hypogonadism. So there's something that's wrong in the testicular or the gonads, and that usually presents with elevated LH and FSH, or if there is secondary hypogonadism, which there is low FSH and LH. And so you can see that there's congenital causes in each and acquired causes. And this is just a list for your reference. So we usually get a bone age, and you can see that's a recurrent theme for us. And then we do labs, LH, FSH, estradiol, or testosterone. And then you can consider other labs because, like we said, there are illnesses that can present with delayed puberty. And I wanted to emphasize this, that LH and FSH is low both in a constitutional delay of growth and puberty and hypogonadism. So how you differentiate is really clinically following them up until they're adults. So in a child with constitutional delay of growth and puberty, they eventually do get there. They do go through puberty. It's going to be late. And the way that I ask parents, the child comes in with late puberty, I ask them, when did dad or did dad grow after high school? So that's really important. I don't ask about shaving because there's just so much variability with shaving. I really do ask, did your father grow after high school? And also for the mom, I asked when was her first menstrual cycle. So eventually they get there, but with hypogonadism, they do not go through puberty. So you just following up with them is really important. And then there are certain labs that we get called Inhibin B and AMH, or anti-Mullerian hormone. And these are helpful for endocrinologists because if they're like in the extremes, they're very, very low, you consider hypogonadism. But most of the time they're not helpful because they're kind of in that in-between range. So this child that we just talked about was a 14-and-a-half-year-old male with no signs of puberty, negative workup, without evidence of biochemical puberty, and a bone age that was slightly delayed. So this child was started on testosterone. That's how we treat it. Late puberty, we do start testosterone. And then the constitutional delay of growth and puberty, we generally start testosterone to jumpstart puberty. So it's a very short course, usually 6 months, 4 to 6 months. And then that sort of jumpstarts puberty and helps them attain a height that's sort of gets there faster. This child on 6-month follow-up, there was no interval testicular growth, but noted secondary sex characteristics. So no testicular growth means no signs of puberty. So we then continued the testosterone and then ramped it up until it was like an adult testosterone dose. And then 2.5 years later, his testes were still prepubertal size, but he's reached the height that pretty much his midparental target. So his testes being the prepubertal size, again, the first sign of puberty in a male is testicular growth. So he does not have puberty. He did not go through puberty, so he has hypogonadism. So, and to contrast this with a child that we start testosterone on and then we see testicular growth, that child has late puberty. This is just for your reference. Generally, they're indistinguishable, but you can see that there are some like small things that you can sort of see more in hypogonadism versus late puberty. this is what I was talking about. If you start, this is a growth chart, and you can see this is a child that was treated with testosterone, and a child, and the same child, hypothetically, if was not treated without testosterone, you can see that eventually both of them get to the same height. But then if a child is treated with testosterone, they get there quicker. So why do we treat late puberty? You're like, well, they get there anyway. It's really for social concerns. The child comes to us, they've lost hope. They have low self-esteem, and that generally leads to social concerns, declining academic performance. So we help them get to their adult height, but get there quicker. So then when they compare themselves to their peers, sometimes it helps with the self-esteem. And I talked about a short course of testosterone to jumpstart puberty. And generally we see more males, but I do add estrogen there. And then should see secondary sex characteristics, growth spurt, and increase in testicular size. Last case, so this is a 16-year-old male followed by ped endo for type 2 diabetes. And it is insulin dependent. His weight, you can see here, height, BMI is elevated. He has lack of secondary sex characteristics on exam. He has acanthosis, and his testicular exam is mostly like in the very early stage, so 3 to 4 mLs bilaterally with Tanner 4 pubic hair. And he did have gynecomastia. So you can see he's very tall. He has gynecomastia and small testes. I got labs. So his LH was 24, FSH is 31. So both of those are elevated. His testosterone is low. So what is the diagnosis? Let's go here. It's going to be a little bit of a delay, but hopefully the audience is still here. Okay, there we go. Our questions are coming in. So we have hypopituitarism. We did have a C as well, but it disappeared. Klinefelter. Okay, so for the sake of time, I am going to go back to my presentation and find where I was. So, right. The answer is Klinefelter syndrome. So this child had type 2 diabetes, had a small testes, had gynecomastia, was very tall. So this is consistent with Klinefelter syndrome. And the labs are really what differentiate between the other diagnosis that you see there. So the LH and FSH were high and the testosterone was low, indicating that there's really something wrong in the testicular area, not in the brain, right? If it's central, then you get a low FSH and LH. So this is differentiated between primary and secondary hypogonadism, and you can see for your reference again all the different causes. So just a note about gynecomastia, it's very, very common. We talked about this, 50% of boys during puberty. So if you have a child who has not gone through puberty, who has gynecomastia, that's an immediate referral. So if any of the children with gynecomastia, a percentage does persist, usually it does resolve within 2 years, but if it does persist, then surgery is really the only way to get rid of it. Some boys, they bind it and that helps them. But if they actually want to get rid of the glandular tissue, it's with surgery. And then I mentioned this, but any pre-pubertal gynecomastia needs workup ASAP, and really you want to work up and rule out malignancy. So take home points. Don't forget the GU exam, please, at every well visit, because sometimes we see patients and we, again, that child, the last case, I follow him for type 2 diabetes, but found Klinefelter syndrome. So differentiate between puberty and adrenarchy. So puberty is the activation of the HPG axis. Adrenarchy is increased adrenal hormones. Remember normal variants. So premature adrenarchy, pubarchy of infancy, premature thelarchy, which is breast development. Refer to us. You can refer anyone, obviously, but especially if they have rapid or no progression, they have an odd tempo, there's concerning signs and symptoms, there's growth delay or acceleration. Precocious puberty, so it's idiopathic in 50% of boys and 90% of girls. So I'm very worried if a boy comes to me with precocious puberty. I do work him up and I do get an MRI, but I don't always get an MRI in females. And then delayed puberty needs follow-up to differentiate between late puberty and hypogonadism. So thank you. And I'd be happy to take any questions.
Yeah, thank you so much, Dr. Davallo. We are now open for Q&As at this time. Submit your questions in the chat box and we will make sure or try our best to get to everything. And I actually have one already, and it's as a PCP, if I have a patient who needs a bone age or lab, should I get these or refer to you?
Yeah, so we actually read our own bone ages. So the radiologist does read it, but we do look at the atlas and read it ourselves. So we do like it if we order it and we're able to actually see the x-ray. So a lot of times PCPs will send us the report, and the report is helpful to get a ballpark of whether the bone age is advanced or delayed. But sometimes, you know, if the child, if it really matters what the height is and those details matter, we like to really look at it. And same with labs, because sometimes we add on labs and then it's a separate blood draw. But again, I mean, anyone's welcome to do labs or bone age, but we do like, especially for bone age, to be done after the referral.
Excellent. And next question is, how long do you treat patients with precocious puberty?
Yeah, so we tend to treat patients until the average age of the onset of puberty, which is around 10 in a girl. So sometimes we do treat up until that point. And then for boys, about 11 and a half, which is the age of the onset of testicular growth. So we look at a lot of things though. So if a child just doesn't want treatment and it's not necessary to treat precocious puberty, a lot of times, especially if they're age greater than age 7. And the studies have shown that if you treat a child below the age of 7, there definitely is a benefit to increasing adult height. After age 7 is kind of a case by case. So some people show benefit and some don't. So really we talk to the families, we see what their goals are, and psychosocial concerns, that's also important. So see, especially in children with intellectual disabilities, that might be a concern as well. So we approach it based on sort of case by case.
And then with those patients that have precocious puberty, how do you decide whether or not to get an MRI?
Yeah, so in boys, all boys with precocious puberty, we get an MRI, and that's because 50% of them are idiopathic. So the other 50%, there's something wrong. So there's either, you know, a brain tumor or another tumor or some other genetic cause that they have the early puberty. So really you want to get in all boys, we do get an MRI. In girls who are very, very young, so if they're 6 years or under 6 years of age, we tend to get an MRI. But if they're older than age 6, especially for African-American girls, because like we said, that African-American girls tend to start breast development a little bit earlier. So in those girls, we don't always, you know, get an MRI, but in the very, very young girls, so less than age 6, or those with neurologic symptoms, we would get an MRI.
Excellent. And in the chat here, can you repeat the age around that boys stop growing?
17, bone age. So we're talking, so there's chronological age, so how old the child actually is. And then there's the bone age, how old the body thinks it is. So a bone age of 17 is when a boy has had 99% of their growth complete, and a girl a bone age of 15. So that child could be 14 and had an advanced bone age to 17. So they've stopped growing, right? So generally early bloomers, or the child could be like 21 and they could have that bone age of 17. So it's the bone age.
Yeah, thank you. And is there an age at which we need to refer a child if palpable breast tissue has persisted since birth?
Yeah, so those are kind of tricky. So usually if they've been persistent, we see a lot of that. And it's really it's just to give context to everyone, breast tissue can be seen after birth if there is maternal estrogen that is transferred to the baby, and that could be a male or a female. So, and it generally does resolve, but in some babies, it does persist. And if the child, I would follow the growth of the child. If the child has normal growth, no other signs of puberty, and otherwise is completely well, we just follow them. And sometimes what happens is that the glandular tissue does decrease a little bit, but and then might increase again in sort of like the less than 2 years of age. So it can look like it's persisted throughout this whole time, but it really didn't. So we see a lot of different variables, but I would say as long as the growth is normal, the child is otherwise normal, and there's no other signs of puberty. And I like to look at the vaginal sort of mucosa, and you can tell if it's estrogenized or not. And so if there is effects of estrogen on other parts of the body, definitely that's more worrisome.
Thanks. And another question, if we need to refer to surgery for gynecomastia, any recommendations on where specifically to refer?
Yeah, locally, so VCU does do breast surgery. I honestly have not referred anyone here yet, but I do know that as an academic center, we do gynecomastia.
Thank you. And last question that I've got right now in front of me, unless others have additional, is what percentage of patients with premature thelarchy progress to central puberty?
Yeah, so premature thelarchy, we talked about it as being benign, and usually it just goes away. But there is a small percentage of patients whose breast tissue progresses, and it even progresses to central puberty. And that percentage is around 9 to 14%. So you can say around 10% of patients do progress. Generally, those children are greater than 2 years old, and then they sometimes, the way that you can catch that is again following them, so following their growth, seeing if they have other signs of puberty. The only thing I would say is sometimes when you do labs, LH, FSH, early, so when they're around like infant to toddlerhood, you could see an elevated LH and FSH, and that is due to, I didn't talk about this during the presentation, but it's due to mini puberty of infancy. So there is a period of time, and it's generally the first couple of months, but can persist beyond that. That infants do have an activation, and it's very brief, of the hypothalamic pituitary gonadal axis. And this activation generally increases the testosterone and estrogen, and you have pubertal LH and FSH, but the child is just in mini puberty and don't see signs of puberty. So, and that's really because of the receptors. At the receptor level, the estrogen and testosterone receptors are not really activated. So you don't see the signs of puberty, but you see this higher gonadotropins that are in the pubertal range. So that's how it gets tricky, but in general, we sort of watch for symptoms.
Amazing. So some really great comments and questions in the chat today. Very informative, great presentation, and I concur. So thank you so much for your time this morning, sharing your expertise and information with our folks across the state and beyond today. So we really do appreciate you so very much. And we have run out of time. So certainly if anybody has additional questions, they're welcome to reach out to me via email or you. And we'll be more than happy to continue to connect and increase knowledge as needed.
Yes, thank you so much for having me. And thank you all primary care physicians out there for having faith in us and sending us your patients.
Yes. Thanks, Dr. Davala. Have a great rest of your day.
Thank you. You as well.
All right. Good job. Thanks to everyone for your participation and your questions. We want you all to get the most out of today with your questions. So keep them coming. Really appreciate it. So next up for us is VMAP and the Cameron K. Gallagher Mental Health Resource Center update. So I now have the pleasure of introducing our next two speakers, Rachel Reynolds and Amanda Long, who will be providing us an update on VMAP and the Cameron K. Gallagher Mental Health Resource Center. Rachel Reynolds is the VMAP call center and care navigator lead for Children's Hospital of Richmond at VCU. She worked with a team of leaders from across the Commonwealth to launch the Virginia Mental Health Access Program, which we all know as VMAP, a psychiatric access program that officially began in the fall of 2018. Rachel holds a master's degree in communication disorders from Appalachian State University and is currently pursuing her PhD in organizational leadership from the Washington, D.C. campus of the Chicago School of Professional Psychology. Miss Amanda Long is the Cameron K. Gallagher Mental Health Resource Center, which sometimes we'll refer to as CMHRC. She's our program manager for Children's Hospital of Richmond at VCU, and she holds both a bachelor's and master's in social work from VCU. Ladies, thank you so much for being with us today, and I am ready to turn it over to you all.
All right, well, thank you so much. We are so excited to be able to present some information about mental health resources to this group. I know we have a short period of time to share a great deal of information, so we're going to try to be efficient so we can save some time for your questions. And sure my slide is working here. So the first set of slides that I'm going to present to many of you who are working and practicing medicine here in Virginia are not going to be a surprise. We know that mental health, even prior to the pandemic, was a challenge in that 83,000 of Virginia children have had at least one major depressive episode. And many of these children do not get the adequate mental health treatment that they need. And a lot of that is related to access issues. And of those with severe depression, only 28.3% do receive consistent treatment. So we know that that treatment is and access are an issue. Further, we know that suicide is the second leading cause of death for those ages 10 to 24. And there's a Virginia Youth Survey that's done every 2 years that surveys both middle and high school students. And the last one was done in 2019. And it showed that 1 in 4 females and 1 in 8 males in our state have seriously contemplated suicide in the past 12 months. This was done in 2019. So this even precedes COVID-19 and many of the challenges that we know that COVID has presented related to mental health for our youth. Further, 1 in 3 Virginia high schoolers who were surveyed in that same survey felt sad or hopeless almost every day for more than 2 weeks in a row. And 12% of Virginia high schoolers and 14% of middle schoolers made a plan on how they would attempt suicide. These are staggering statistics, and they seem very hopeless and very challenging. And one of the things that we know is that primary care is one of the primary access points for families and individuals, children and adolescents who are experiencing these mental health challenges. 64% of Virginia localities have a mental health professional shortage. In fact, Virginia ranks 41st in terms of mental health workforce availability. We know that only 87 out of 133 localities in the Commonwealth of Virginia, 87 out of 133 of those localities have no child and adolescent psychiatrists available at all. And in fact, there's only 13 child and adolescent psychiatrists available per 100,000 children below the age of 18. So this is a serious workforce issue. Only 5 localities actually have what the ACAP considers an adequate supply. So with these staggering statistics, what is there to do about this? It seems like an overwhelming problem. And in order to be able to serve primary care physicians in a way that they can adequately serve their patients, we know that we're never going to catch up. We're not going to have enough child and adolescent psychiatrists or even psychiatric nurse practitioners to serve the statewide need. And that is the reason why we created a mental health access program. It's actually based on a model that exists in about 40 other states. So almost every state in our country now has some kind of mental health access program. The original one was started in Massachusetts. It's known as MCPAP. And every state's program is a little bit different, but I'm going to share some information about what VMAP does, what we do to serve the state needs, and also how you can access some of these programs. So we have what we consider to be 4 pillars of VMAP. The first is education. We know that as primary care providers, you want more information on how to serve these patients adequately in your practices, particularly patients who have mild to moderate mental health challenges, whether that's ADHD, mild anxiety, mild to moderate depression, and to feel confident in serving those folks. And I'll talk a little bit later in the presentation about what some of those options are in terms of primary care provider education that's available to you either for free or at low cost to build your confidence in serving these patients in your practices. The second is access to a primary care provider to a specialist, whether that's a child and adolescent psychiatrist, a licensed mental health provider such as an LPC or an LCSW, to answer your questions. That could be about medications, types of medications, medication interactions, or where to go with a patient who's presenting with some more complex clinical challenges. Along with that, we offer care navigation services. It's currently available in some regions. And again, I'll talk about this a little bit later in the presentation. But care navigation is connecting families with additional mental health resources. So outside of psychopharmacology or what you're able to provide in a primary practice or in a specialty care, because we know that the mental health system is complex. Insurances present other challenges. And so this is a way to help connect families with the resources that they need. Finally, another element of VMAP is telehealth visits. When this was first formed, this was before the pandemic happened. And of course, now everybody's doing telehealth. But one of the things that we are working to build in VMAP is when primary care contacts us and says, I have a patient who's presenting with these challenges, sometimes the specialists need a little bit more information. And so one of the things that VMAP is going to build in the future is access to an additional telehealth visit with a specialist that may provide quicker access. It wouldn't be for ongoing care, but it would be for quicker access to answer some of those immediate questions that a provider and a family may have. So as you've worked in the state of Virginia, you probably know that we often divide the state into regions in order to better serve our families. These are the 5 regions of VMAP, and the regions are formed for a couple of different reasons. One is you'll see the stars, and those represent our partnering hospitals that we're working with to create what we call regional hubs. So in each regional hub, when VMAP is fully formed in a hub, we have the full-time equivalent of a child and adolescent psychiatrist, a full-time licensed mental health provider, and at least one full-time care navigator to serve the needs of that particular region. And we currently have hubs fully built in our northern region, and our host hospitals in that region are Children's National Medical Center and Inova Fairfax, the Keller Center, and in our eastern region, which is hosted by Children's Hospital of the King's Daughters. We're also excited to report that we will have a central hub starting very soon here at VCU Health System and Children's Hospital of Richmond at VCU. And then we're currently building capacity in our Western and Southwest regions. We're partnering with UVA Hospital as well as Central Hospital systems in Lynchburg and Charlottesville. And we'll also be partnering with Mount Rogers Community Services Board to provide some care navigation resources in the far Southwest. So this, if you do live and work in the state of Virginia, it's good to know which region you're in, because when you call our consult line, we're going to ask you to select which region. So you can see our light green is north, our dark red is east, dark green is central, orange is our west, and blue is our southwest. This is a workflow that shows some more how VMAP works. So I mentioned the PCP education, and we will talk again a little bit more about what some of those education options are that are available to primary care. But the other thing that's available is a call center line, and this is open 9 to 5, Monday through Friday. You can call the number, and we will present that later in the slides. And when you call the number, we will ask, whoever answers the phone will ask some brief information about the patient, get some additional information about the best contact for you as a primary provider. And then based on your need, you'll either be connected with a behavioral health provider, such as a child and adolescent psychiatrist or a licensed clinical social worker, and or a care navigator who can provide additional needs for your patients. Again, the telepsych visits are something that we are adding to the VMAP workflow in the near future, but it's not available right now for patients. How did we make all of this happen? Well, it started with a HRSA grant, a state grant, or a federal grant from the Department of Human Services. And that was our seed funding. We received that in August of 2018. Since that time, we have also been included in the governor's budget. So the vast majority of the funds that make VMAP possible come through our state budget. And we received additional funding later this year, actually in late 2020, that is really fully funding VMAP. So as we have received this funding, it's given us the opportunity to bring these hubs online, to staff and contract for these positions that will provide child and adolescent psychiatrists, other clinical staff, and care navigation resources in each of these regional hubs that I showed on the map. So currently we have full staffing in our north and eastern regions, and we expect that central, west, and southwest regions will have additional care navigation and LMHP consultation services available by the end of this calendar year. I wanted to mention some of those additional education options that are available. Some of you may have heard of the REACH Institute. It's a national institute that provides a weekend training program. There's actually one going on in our central region this weekend. And these had traditionally been in-person weekend training programs. They're currently happening in a virtual format. They also include 6 months of follow-up coaching calls. The faculty for this program includes primary care providers, child and adolescent psychiatrists, and other specialists who provide a full weekend-long training in all kinds of clinical issues that primary care faces related to mental and behavioral health. So you can look at our website, that's at vmap.org, to find out when there's new opportunities. Normally these training programs cost thousands of dollars, but we are able to provide this program to primary care providers for a $100 nominal fee. And it includes a good number of CMEs as well. The other thing that's available is our Project ECHO cohorts, and the Project ECHO is a year-long learning collaborative. So it's a slightly different learning format. It also covers many topics related to mental and behavioral health. Every month, the Project ECHO cohorts meet for an hour on Zoom, and there's a 20 to 30 minute didactic training. There's a case presentation and discussion. These cohorts are made up of about 20 to 25 primary care providers, along with our teaching faculty. The current cohorts for this year, again, are full, but there are new cohorts that will be added starting in the fall of 2021. So if you're interested in this opportunity, this is also free and it's available on our website for more information. And finally, the other thing that's being offered through the state chapter of the American Academy of Pediatrics is our QI cohorts. Oops, I went too fast. Our QI projects are specifically designed to support you in improving screening within your practices, because we know that utilizing mental health screenings leads to better access to primary specialty care for the children that need it. And this offers MOC Part 4 credit. So again, there's another project planned for, I think, later this spring, and there's more information about this on our website. Before I transition over to Amanda, I just want to say that as the VMAP program has rolled out over the last year and a half, we've received some really great feedback from the providers who are utilizing the consult line and accessing the education components. It really helps them answer the questions that they need without needing to wait for a specialist, which we know can take months. The way that you register is to go to our website. You'll go to the primary care section, and there is a brief survey that asks some questions about yourself and your practice. It takes probably about 10 minutes to do. We do ask that you register, and that way you can make sure that you receive any updates that happen as VMAP is rolling out across the state. So this also gives you access to the consult line. There is no cost to providers to call our call center. We'll contact your practice, and this is the number. It's 888-371-VMAP or 8627. We are open Monday through Friday, 9 a.m. to 5 p.m. We do accept our last call at about 4:30, and that allows our providers to complete that final consult. If you call after hours, you can leave a voicemail, and your call will be handled in the next business day. We do ask for some provider and patient information, and then you can get a call back from the psychiatrist within the next 30 minutes. This is available for patients through 21 years of age. We know some primary care providers may serve individuals who are older than 21, but that is where our service limits are right now. It is not a line for families to call directly. If we're calling about care navigation and service access for care navigation, we'll get some information about the families, and then our navigators will connect with the families directly. It's also not a crisis line for patients. It's meant for non-crisis questions, and it is for Virginia patients only. I'm just going to end really quickly with my portion, just to say thank you to all of the partners. This is a multi-agency, multi-hospital effort that has been a couple of years in the making, and we're excited to continue the growth of our program. So with that, I'm going to turn it over to Amanda Long. She's my partner and program manager of our Cameron K. Gallagher Mental Health Resource Center, and she can talk about additional care navigation services that are available through our program there.
Thanks, Rachel. Yeah, like Rachel said, the CMHRC, we consider that as sort of the family. We provide care navigation for family members, whereas VMAP is more so for primary care physicians. So we will just dive right in. We like to think of ourselves, we like to use a metaphor with a map. And I start off by saying, how do you all get around? How many of you use a navigation service like Google Maps, Waze, or GPS? And why do you use it? Well, because it helps us get from point A to point B, and it's pretty seamless. What makes for good versus bad navigation systems? Paper, so when we think about paper maps versus electronic, what are the disadvantages and advantages? So why don't we use paper maps anymore? That's pretty obvious. It's because they can be complicated, cumbersome, they're out of date, and So we've evolved and we now use GPS. And we do this because it's more up to date. It has voice navigation. It indicates flow of traffic. It makes our journey much easier. So we like to say that the CMHRC is kind of like it acts as a GPS for families. It guides families as they develop their own roadmap and supports them each step of the way as they navigate the mental health system. So how do we do this? We have a team of family navigators. Our navigators have their own lived experience with the mental health system, either as an individual or a family member, so they can offer their own emotional support. This lived experience helps them, it gives them the ability to really understand and empathize with families, and you know, they're able to truly help in a meaningful way because they've traveled this road before. So they can they also provide psychoeducation, apparently, just general information about the different services available in the mental health system, because as Rachel said earlier, it is complex and it's a lot to sift through, especially if you've never done it before. So we assist families in accessing these resources, and then we follow up to ensure families get what they need. So that's kind of one thing that sets us apart from maybe some other resource centers or call centers is we follow up and make sure that the families really got what they needed. We are conveniently located inside the VTCC. We're adjacent to the lobby. We're hoping to open soon for open hours, but right now we are not open to the public, so we're essentially operating as a call center, but in the future we will be more in the community. And I neglected to say that we do this, we're able to provide our families with the resources they need by providing or maintaining a robust database. Our provider database includes name of provider, insurance they take, services they provide, wait list, and geographic reach. And so we do our best to keep this database updated. We're really proud of our outcomes. We send satisfaction surveys to all the families that we serve, and we're happy to say that 90% of families who were provided with referrals attended their appointments, and then 80% of families attended appointments and were happy with their providers. So that's really exciting. Here are just a few quotes, feedback from families. For the first time, I feel like someone has listened to me. This program made my life a million times better. And we really like this quote because it just gets sort of to the core of why families access our service. And this was from a mother, I believe. Your caring demeanor and helpfulness that day was remarkable. It is so refreshing to be such a genuinely caring person. We had a time where I felt that I had no direction and I was lost in stumbling across your number that day was truly the first step in saving my son from himself. I cannot thank you enough. So a lot of times are really that lifeline for families, which is really invaluable. How families find us, they can find us on the web, mentalhealthforkids.org. You can also call us directly. And we accept direct referrals from PCPs or other medical personnel. And then we send follow-up reports to providers when we receive those direct referrals. So we kind of close that loop and let doctors know that we followed up on that request. We do have a referral form that is available for download on the CHOR website. We do like to say, please make sure the parent knows that you're providing this referral to the resource center. We are a family-driven resource, so we certainly do not want to contact families with something that they don't need or didn't ask for. We are operating Monday through Friday, 9 to 5, voicemails. If you call and the line and a navigator isn't able to answer because they're talking to somebody else, you can leave a voicemail, and that's usually returned within 1 to 2 business days. We do have a secure fax system as well. And then our referral forms and a printable one-sheet info flyer is also available on our website. And that pretty much wraps it up. Anyone that has questions, I think we have a little bit of time.
So if you have any questions, you can put them in the chat. I know Lexi will come back on and let us know if there's any additional questions. And just want to reiterate that information about VMAP can be found at vmap.org. And then there's additional information about the Resource Center on the Children's Hospital website.
Thanks, Rachel and Amanda. And I do have a couple of questions. So specifically for you, Amanda, what are some typical reasons that families might be referred to the Resource Center?
Sure. So, maybe a family has seen a doctor and the doctor thinks that the youth needs or would benefit from outpatient counseling, therapy, or a variety of different therapies, play therapy. Sometimes families are in need of psychological evaluations or various testing for autism. The needs can really vary. And then, like we talked about before, families can call directly if they're trying to find a therapist for their child, or they just don't know where to start. That's really a great.
So you're a good place to start above anything else is a pretty important takeaway. Very good. And we have a question in our chat. What is the cost for families for family navigation? Who runs it? And are they professionals or are they volunteers?
It is completely free. This is what makes our program extremely accessible to the community. And we are staffed by, we do have volunteers that help with open hours when we do open back up to the public, but they are paid employees and were hired because of their lived experience, but also because of their professional experience as well. We have a variety of folks on staff. We have someone with a nursing background, someone with a MSW, someone with experience in the health system. So we're a small but mighty team, but very knowledgeable. And
yes, and so they're all health professionals. Yeah. And this is a great question, and I know the answer, but I'll let you answer, Amanda. Do we only work with families in the Richmond area?
No. We are technically we are available to the entire state. A large majority of our referrals and requests do come from the Central Virginia region, but anyone from throughout the state can call.
Wonderful. And is this covered by insurance or is it self-pay?
It's free, so
it's a free service. Yes.
Yeah, we don't collect any insurance information. And one of the reasons why it's free, I just want to throw out too, is that all of our funding comes through grants and individual philanthropy. And that's what makes the Mental Health Resource Center possible. So we are grateful to our grantors and our funders who make this program available, but we don't collect any insurance information other than knowing what insurance they have so that we can connect them to resources.
Yes. And again, I do want to mention that if you go to not only the VMAP website, but the chrichmond.org website, there are tabs to link to these things to answer these questions. And very important for you all to know that we are statewide. So the whole state of Virginia, and I know we have some out-of-state folks here, but all of you that are here joining us from the state, this is a service that is available to you. Rachel, to participate in VMAP, are physicians required to register?
It is not officially required. However, we strongly encourage it. It really helps us, especially as we're building our program, so we can maintain communication with our registered providers. As you mentioned, the registration's on the website. It takes maybe about 10 minutes to complete that registration. So that's what we ask.
And for someone to be able to call into VMAP, do you have to have any previous REACH training or involvement with Project ECHO, or anybody can call at any time?
Yeah, you don't have to have completed those trainings. You can call us if you have any kind of question about a patient that's related to mental or behavioral health.
Beautiful. You ladies are wonderful. You have provided invaluable information for all of us regarding pediatric mental health care and the support services that you offer. And we thank you both for sharing your knowledge.
Thanks again for this opportunity.
You're welcome. Have a great day, ladies. All right. Hope you guys enjoyed that and had some valuable information there. And we are going to keep this day moving forward. Our next topic is the management of sickle cell disease for babies, teens, and a little in between. So I am so happy to be joined by Dr. Elamine and Miss Jennifer Newland, who'll be speaking with us about the management of sickle cell disease. Dr. Elamine is an assistant professor of pediatrics at VCU, specializing in hematology oncology. She received a Doctor of Osteopathy degree from Touro College of Osteopathic Medicine, completed her residency at the Medical College of Georgia and fellowship at the Medical University of South Carolina before joining us at CHOR. Jennifer Newland is a certified physician assistant at Children's Hospital of Richmond at VCU, specializing in hematology oncology. She earned a master's degree of health sciences and completed the PA program at Duke University School of Medicine. Ladies, thank you so much for speaking with us today, and I will now turn it over to you.
Thanks, Lexi. Thank you so much, guys, for being here today with us. We're anxious and eager to share some new information, hopefully for you in reference to sickle cell disease. So Nadir and I are tag team in this presentation. So today we will be talking a little bit about some big topics, I guess, with sickle cell. We're going to look at baby things, teen things, and some things in between. And we got some of these topics for this talk from you guys, from our peers and other folks that we work with to help us guide this talk. So here's our agenda. We have, it looks like a lot to cover, but hopefully we can get through it with plenty of time for questions. And we do not have any financial disclosures. So just to kick it off, so for you to know, sickle cell disease obviously is the most common inherited blood disorder in the United States. And it's estimated that about 100,000 people in the United States are living with sickle cell disease. And we don't know that exact number, but that is the estimation that we have. And we're getting more and more data as the CDC tries to get registries of patients so we can have an accurate reflection of the population in the United States. You'll see the numbers here of live births in the United States, how common it can be to have sickle cell disease. So it's 1 in 365 African-American babies, and about 1 in 13 African-American babies are actually born with sickle cell traits. So it's very common to be born with sickle cell traits. So it's important for you and for us to understand that as well and be able to provide education to families about the genetic inheritance of sickle cell. At CHOR, we follow approximately anywhere from 300 to 320 patients in our comprehensive sickle cell clinic. And the thing I love about taking care of our sickle cell patients is that I and our team get to care for patients from infancy until they are adults and they're graduating and they're headed into the adult clinic. And that's just a joy to get to know the patients and the families and to earn trust with their families. So that is just a joy of caring for this population. So we have to give a little bit of a background. So sickle cell disease, obviously there's an abnormal hemoglobin, the hemoglobin S, or the sickle hemoglobin. And when we talk to our patients and families, we talk about how a normal red blood cell is like a donut. It's can flow easily through the blood vessels. But when a sickle hemoglobin when there's deoxygenation, then the sickle hemoglobin can clump together, it can form fascicles, and it stretches out and it deforms the shape of the red blood cell, and it causes it to have that sickled the sickle shape. And so obviously, as you can imagine, that sickle shape is very hard for the blood cells to flow in the blood vessels. And so you get those, it gets stuck in the small capillaries. And this is what causes complications. This is what causes patients to have pain and other complications. And there's a lot of things that are happening on the cellular level: endothelial damage, inflammation, elevation in the white blood cell counts, and all of those things are important to know what's going on. So you can see that down here as well, the hemolysis and the endothelial dysfunction. And so obviously, because it's a disorder of the red blood cell, we can have complications in our patients from head to toe. So these patients can come with problems with their eyes, down to leg ulcers. And so you can see this list of complications, both acute and chronic complications. And we manage all of these things in our patients and try our best to do preventative care, right? So to try to prevent these things from happening, to prevent them from having complications. The most common complication that our patients have is pain. And so that is something that we deal with a lot. So we said we were going to talk about babies a little bit. And so I think it's important when we're thinking about our sickle cell patients where things begin. So sickle cell disease is an inherited blood disorder. So babies are born with it. And we get the newborn screens, and you get the newborn screens in your office. And so when those newborn screens come across and you see the critical value notification, you know, we have to do something about that. So we will get the newborn screen, you get the newborn screen, and we love to see these babies by the age of 2 months. We want to see them early in order to be able to start them on, whoops, sorry about that. Didn't want to, let's go back to where we are. I don't know why my computer decided to do that. Sorry about that. So we want to start our babies on prophylactic penicillin by 2 months of age. And that first initial visit that we have with families is really an opportunity for us to provide basic education in regards to fever, in regards to pain and dactylitis, which is swelling in the hands and feet. Learning how to palpate for the spleen so that they know when the spleen is enlarged that that's considered a medical emergency. Oftentimes, when we're seeing patients in that initial visit, we're helping to clarify the diagnosis. We're helping to provide education that maybe, you know, things were unclear because the family history is unknown and parents weren't aware of their sickle cell trait status or their thalassemia status. And so that is important for us to be able to go through with the family and provide that education. We often will get calls or will be asked by pediatricians more specifics on how to interpret the newborn screen. So I wanted to go over a little bit of that and to help maybe answer some questions about the newborn screen itself. So when you get a newborn screen that comes across that says FS, then that is a patient that has, most likely has homozygous sickle cell disease, which is the most common type of sickle cell disease and the most severe type of sickle cell disease. These patients inherit sickle cell trait from both of their parents. So that is the most common thing to see. Patients can also have, with that genotype FS, sickle beta 0 thalassemia. And that one's a little bit trickier to figure out unless the family knows their history. That one's a little bit hard. We figure that out down the road based on lab values and microcytosis and other things that we're looking at. So you might not know that up front, and we might not be able to tell the family right away. There's also with FS, a patient could have sickle hereditary persistence of fetal hemoglobin. This is more rare, but this is when a patient gets trait from a mom or dad, and then they get fetal hemoglobin inherited from their mom or their dad. This This genotype is one that is similar to sickle cell trait. So these patients do not need to be followed and monitored like a patient with sickle cell disease because they rarely would have any complications. They don't need to take penicillin. And so we sometimes will follow them some, but we don't always have to follow these patients. Then if the newborn screen says FSC, then that means that they have fetal hemoglobin, sickle hemoglobin, and then the variant C hemoglobin. So sickle C disease, this is less severe, and typically patients have less anemia with this type of sickle cell. Then there's FSA, which is sickle beta plus thalassemia. So the A is the adult hemoglobin. And these patients, when I say plus, A is good, because if they have some adult hemoglobin, this is protective for patients. So they have less complications. They're not as anemic, and they might not even have anemia. And so this is important to kind of know the distinction for this type. Then there's sickle E disease, and there's also a wide variety of other variants that may pop up. So the SV or the FSV newborn screen is one that often we will get questions on, but we will figure that out in our clinic by getting additional lab work and working with the family to figure out the variant that is there. So sometimes we'll get the question, well, how do we know the difference between sickle cell disease and sickle cell trait? In the newborn screen, when you get the report and it will say critical, then that is a patient, that is a baby that has sickle cell disease. And so you make sure that, because sometimes families will come in thinking that maybe if they have the newborn screen says FSA, that perhaps maybe they don't have sickle cell disease, that maybe they have sickle cell trait, and that is not true. So it's important to think about when you're looking at the newborn screen, the proportion of hemoglobin is based on like the order that it's in. So FAS, there's going to be mostly fetal hemoglobin, and then next is the A hemoglobin, which is that adult hemoglobin, and then next is the sickle hemoglobin. So the sickle hemoglobin is lower, so these are the ones that have trait. But if it's FSA, the sickle hemoglobin being second means that this is a patient that actually has sickle cell disease. And so that's an important distinction to know, because we have had some patients come thinking that maybe they have trait when indeed they actually do have sickle cell disease. And here you can just see the types of sickle cell, and it has on the left is the homozygous sickle cell, which are the most common and the most severe. And then it goes down to the sickle beta plus thalassemia patients to the right, which are less severe. And again, we talk a lot about, obviously we're preaching to the choir here for our pediatricians, we want preventative care for our sickle cell patients, just like you want for all of your patients. And so we really want to be proactive with our patient population, starting them on the penicillin. We prescribe penicillin to all of our sickle cell babies. So SS, all the different genotypes. In the guidelines, in some other centers, they only prescribe penicillin prophylaxis for SS patients and S beta 0 until the age of 5. But we have historically used it in all patients, providing education that with SC and S beta plus thalassemia patients, if those families are opposed to it, we do education with them, and we'll support them in some of their decisions because the data is not as strong in that population. Patients will stay on penicillin until they're 5 years of age unless they've had a splenectomy. If they've had a splenectomy, then we would continue penicillin indefinitely. And if they've had a history of having sepsis or bacteremia, then we'd also consider continuing the prophylactic penicillin. You can see the doses here. The dosing is pretty stable until they're 3, they go up in dose. And then at 5, we would stop unless those exceptions that we mentioned. Again, so with vaccinations, I'm always amazed at how all the pediatricians can keep track of all the vaccinations that you guys have to give, because we only have like 2 that we really need to worry a lot about, the pneumococcal and the meningococcal. And sometimes we still get confused with things and have to, figure out exactly, okay, what are we, doing here? So I commend you guys for the vaccines and all that you do with that. So with our sickle cell population, because they are at increased risk of having infections that can be life-threatening. So we want to give them vaccinations that help prevent that for a high-risk patient population like sickle cell. So that's the pneumococcal and the meningococcal vaccines. And I will go through just a quick overview of these 2 vaccines that we use. So you guys are typically giving them the Prevnar 13, and once they've gotten fully vaccinated with the Prevnar 13, and we do try to check on that and make sure they are fully vaccinated before we give them the Pneumovax 23 at age 2. we then give the second Pneumovax at their 5 years of age, so 3 years after the first in our clinic. And we do not boost the Pneumovax anymore. There's no indication to give additional boosters of Pneumovax, which we used to do it every 5 years, but right now it says just to give the 2. So that's what we're following, those recommendations. And if a patient has not had their Prevnar 13 on time, we will try to help make sure that they get that and then give them the Pneumovax 23 at 8 weeks after that. So making sure that they get that vaccine on time. Now, the meningococcal vaccines. So we vaccinate with Menveo in our clinic is the vaccine that we have used. And so the vaccination with Menveo can start as early as 2 months of age. And this vaccine schedule is based on the age, is how many doses they get. So it can vary between 2 doses or 4 doses. We typically have vaccinated our patients with option 3. You can see here in the highlighted with the blue. And we have opted to do that because we do not see patients at the interval that option 1 would allow us to give these vaccines on time with their routine vaccinations. So this is one area that if pediatricians are giving Menveo or willing to give Menveo or meningococcal coverage, that would be ideal for the pediatricians to work with us to go ahead and start vaccinating sickle cell babies with their routine vaccination schedule, so that they would get their vaccines, before they're 2 years of age, and that would be ideal. So we're seeing some of our colleagues at VCU doing that, so that is helpful. But like I said, we typically start at age 2, and then it's the 2 initial doses of Menveo, 8 weeks apart, and then they get an additional dose at 5 years of age, so 3 years later, and then that is boosted every 5 years. And you'll see the guidelines or the recommendations for Menactra, which we don't use anymore. Menactra can be given as young as 9 months of age, and the dosing on that's a little bit different if you give it when they're younger for the second dose. And Menactra is also recommended to be boosted. When we're looking at vaccinating with meningococcal B and to cover our patients because they're considered to be in the high-risk category that should receive meningococcal vaccines, we have opted to use the vaccine Bexsero. So that's the one that is given at CHOR. It's a 2-shot initial series. And we can start using this or vaccinating at the age of 10. And I will say that we have, in preparing for this presentation, I noted that over the last year, there has been a new recommendation. In the past, there was no recommendation for patients to get a booster for meningococcal B. And so they just got the initial 2 shots and that we just called it a day and they didn't get any boosters. Well, now they're recommending boosters more frequently. And so we're actually looking at changing our practice within our population. But the way that it works is you get the 2 initial vaccines up front, the initial shots, and then you boost a year later, and then 2 to 3 years later, and you boost it at a 2 to 3 year interval, as long as the risk remains with sickle cell disease, unless they've had curative therapy, they would continue to have and recommend the booster. Then we obviously recommend flu vaccinations every year, and we encourage pediatricians not to give the live flu vaccine or the nasal mist. And then we also say just to follow the routine childhood schedule. We strongly encourage our patients and families to get their vaccines with the pediatrician on time and to continue to follow up with their pediatricians regularly. And here's just the vaccine recommendations just in the table format that we just went over. Again, prevention, prevention, prevention. So here we are, what kind of things when you're seeing a sickle cell patient in your practice and maybe they haven't come to see us as often as they should, what kind of things can you be helping to remind them and for them to remember, hey, I really do need to go back and see my my sickle cell doctors. And so basically the things that we recommend looking at trying to keep preventative studies is a transcranial Doppler. And so we do the transcranial Doppler, which is an ultrasound of the blood vessels of the brain starting at age 2. And we do that annually in our sickle cell patients that have hemoglobin SS and S beta 0 thalassemia. So both of those patients need to have a transcranial Doppler. And this is looking at trying to prevent stroke. So it's a primary stroke prevention. It's a preventative tool that we're looking at. If this is abnormal, then we end up having to start patients on monthly transfusion protocol in order to prevent stroke. And right now, we only have a handful of patients that are actually on a chronic transfusion protocol because of other preventative things that we're able to do, like hydroxyurea. We also recommend that our patients have an annual dilated eye exam starting by age 10, unless there are concerns sooner for vision. And we are doing this because we want to make sure that they don't have sickle cell retinopathy. This is more common in our patients with SC disease. So super important to remember that even though the SC patients have less pain, less complications, they definitely can have more retinopathy and potentially have loss of vision. We recommend routine dental visits. And a lot of times dentists will ask, is there anything special that we need to think about with our sickle cell patients? We do recommend prophylactic antibiotic if they're having any dental extractions, aggressive dental work, root canal, or the patient has a central line, portacath, or they've had a splenectomy. So those are the patients that we recommend prophylactic penicillin, amoxicillin prior to procedure. Otherwise, they can have routine cleanings without any other safety measures. Now, what about blood work? You know, are there labs that we routinely get? Well, we're hematologists. We love to draw labs. We love to get your blood. So yes, our patients do require blood draws quite frequently when they come to clinic. Most times when our sickle cell patients are in clinic, they're always going to have a CBC and a retic count. We will get a CMP or urinalysis probably once a year in all of our patients. We start getting the microalbumin to look for protein in their urine starting around the age of 10. And then obviously if a patient is on hydroxyurea, or if we're trying to figure out their genotype, we're going to get the fractionated hemoglobin. We're going to get that frequently, the fractionated hemoglobin, to monitor their effect of hydroxyurea. So these are the common labs that we will get in our patient population. And then when it comes to the echo and the PFTs, you were looking at, okay, the guidelines aren't super clear that have been put together. There's not a clear consensus on when to get an echo to look for pulmonary hypertension. We do get echoes in our patient population because for patients that are very anemic or we worry about cardiac issues, but there's not a set schedule for that. So that's clinically driven. We used to start it and always get it around age 10, but that guideline is not clear. But we are still trying to get that on most patients. The pulmonary function tests are is not clear either, but we often have our patients follow with pulmonary. If they have a history of asthma, they've had a history of having acute chest or any other pulmonary concerns, we will have them follow with our pulmonary colleagues to just evaluate their lungs and make sure, again, both of these looking for pulmonary hypertension and other potential complications. All right, so we talked about all the preventative things, but guess what? Things still happen. Our patients still have complications. And one of the big complications, or one of the things that we worry about in our patients, is fever. We worry about that because our patients are at higher risk of having complications or higher risk of having infection that could be life-threatening for them. And so every fever over 101 in our sickle cell population is considered a medical emergency. We don't want them treating their fevers at home with a little Tylenol, a little ibuprofen. We want to know when their fever's over 101, and we want to see them. We want to see them in our clinic. We want to see them in the emergency room. We want to assess them clinically and get this lab work that we've mentioned here, the CBC, the retic, getting blood cultures, urine if it's indicated, respiratory swabs depending on respiratory symptoms, chest x-ray if we're worried about any shortness of breath or abnormal lung exam. So we want to quickly identify and evaluate our patients with fever, and we want to manage those patients with fever with covering them with a broad spectrum antibiotic. We use ceftriaxone in our patient population, and our goal is to get that in them as quickly as possible. So we use ceftriaxone regularly with our patient population. And why do we do this? Well, we do this because, again, patients with sickle cell disease are at high risk of having infection that could be life-threatening, and we know that obviously, with the vaccinations and penicillin has helped to reduce mortality, but these patients are at higher risk of having complications from encapsulated organisms. So they'll have certain bacteria that they're more susceptible to, meningitis. These are the things that we worry about in our patients, and we have to figure out and make sure that we're treating these things and monitoring our patients closely. Patients can also have pneumonia or acute chest syndrome. And this is something that we see when they come in with fever, chest pain, cough. So we're monitoring for that when they come in with fever. And our patients a lot of times can just have viruses, just like patients you see in clinics. They can be affected with various viruses that are in the community. Parvovirus, a lot of times the different viruses that they get, they can have a more virulent course because of their underlying sickle cell disease. So should they stay in the hospital? Should they go home? Just trying to decide on outpatient and inpatient management. And we look at a variety of reasons, but we say, are they a low risk patient? Are there things that are reassuring on exam? Have they been up to date on all their vaccinations? You know, are they well appearing? All of those things, we would consider them to be low risk. Are they a reliable family that if something came back on the blood cultures, if they still had a fever, that they would come back, that we would be able to get in touch with them? So these are all the things that we think about when we're deciding, do we keep our patients or not? Typically and historically, if a patient is under 12 months of age, they need to be admitted to the hospital and monitored closely. So we do admit all of our babies to the hospital. Even if they have a fever, like after they got routine vaccines, we're still going to admit them and follow them for a day or two to make sure that they are doing well clinically. Here's our little algorithm that we have in our clinic just to follow, and it has a lot of the same things as the slide before, just trying to help guide folks to know when to admit a patient and when they are able to go home. So this is just the management here. And another thing that I thought might be helpful, just because I didn't know how many of the pediatricians are aware of the CHOR clinical guidelines that are online, but there's some clinical pathways that are really, really helpful online that are with lots of common pediatric concerns: asthma, croup, pancreatitis, migraines. And one of our clinical pathways is actually on vaso-occlusive pain crisis. And so you can go to the website and they have the little guidelines and the little algorithms written out. And this is our one for sickle cell pain crisis, looking at the algorithm, kind of knowing what to do, how to manage patients that are coming in with pain, since that is one of our common complications. We see patients in clinic for sick visits, and we also see patients in the emergency room if we're not able to accommodate in clinic. So this is our algorithm, and it has a lot of good information. And then it has information on the dosing of pain meds as well, and what to think about in monitoring. So I think that these clinical guidelines can be quite helpful for pediatricians. Whoops, did not mean to do that. And this is our wonderful team here. Dr. India Sisler is the director of our sickle cell program. Dr. Elamine will be speaking next. This is me. And then Alicia's our social worker. And then Jill is our nurse navigator. So there are all of our team members. And here is a picture of Dr. Sisler, who likes to dance. She dances better. I took the picture. She's dancing. We love being with our patients, and we have had the opportunity to host sickle cell retreats for our transition age or our high school patients over the years. Obviously, last year we weren't able to do the overnight retreat, but this is at Camp Hanover, where we do a retreat with our patients, and they stay overnight. We play games, we do education, we talk about careers, vocation with our high schoolers, and we have lots and lots of fun. So anyway, this is a picture of that. Here's our contact information. Just thought we'd throw it up there. Please, 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 if you hear nothing at all today, call us if you have questions. Call us if you have concerns. We love to hear from you, and we'd love to help you. I'm going to hand it over to Dr. Elamine to talk some more about novel therapies.
All right. Hi, guys. Again, thank you so much for having us today and listening to our talk. I'm always happy to talk about sickle cell disease and hopefully generate more interest in this, in my opinion, very interesting disease. So one of the things I wanted to talk to you all about is novel therapies in sickle cell disease. It's actually even exciting to be able to talk about this, because for the longest time, we really only had one drug to manage sickle cell disease, and that was hydroxyurea. And in the last, I'd say 6 or 7 years or so, people have become a lot more interested in sickle cell disease and have been performing sickle cell research and looking at new drugs. And now we have, I think, about 4 drugs for sickle cell disease, which is really exciting to us. But before I launch into the specific drugs, I just wanted to kind of point out that sickle cell disease is a really good place to kind of examine health disparities. And there's been a couple of studies looking at sickle cell disease in comparison to cystic fibrosis, both of which are considered orphan diseases with less than 200,000 people affected nationwide. However, cystic fibrosis has less than half of the amount of patients that are affected with the disease. And when you look at research dollars, you see that there's a significant disparity between the two. So cystic fibrosis receives 3.5 times the funding that sickle cell disease does. And if you look at funding from other smaller organizations, they receive 440 times the amount of research dollars compared to sickle cell disease. And that also includes medications for cystic fibrosis. They have, in the teens, drugs for management of their disease, whereas for 30 years or so, we only had one, and they're just now getting new drugs for our patients. So it is really interesting to look at some of the health disparities that go into taking care of our sickle cell patients and how that affects their ability to be healthy and productive. So one of the new drugs that we have is called crizanlizumab. This paper was published in 2017, basically showing that crizanlizumab helped with the prevention of pain crises in sickle cell disease, which of course is awesome because, as Jennifer said, that's one of the most frequent reasons that we see our patients. In order to understand how it works, it's kind of important to understand some of the pathophysiology of sickle cell disease. So like Jennifer alluded to, sickle cell disease is really a pro-inflammatory state. So we definitely always think about the red cells and what that's doing to the endothelium, but there are also lots of inflammatory pathways that are activated in sickle cell disease, and your endothelium is always very activated, which leads to a lot of platelets, red blood cells, white blood cells kind of coming into the endothelium and causing this very clogged-like picture. And all of that, all of those interactions are mediated by something called P-selectin, which is an adhesion molecule on the endothelium. And so this drug really targets that P-selectin in order to kind of quiet some of those interactions between the endothelium and the red blood cells, the white blood cells, and the platelets, with the hope that that would decrease vaso-occlusion and thus decrease some of the complications of sickle cell disease. So Adakveo, which is the brand name, is a targeted monoclonal antibody. It binds to that P-selectin, which we talked about is also where the platelets and the white blood cells and the red blood cells bind. And in doing so, it blocks the interaction between those cells and the endothelium, and thus decreases some of the vaso-occlusive actions that you see on that activated endothelium. Next. So Adakveo is a IV infusion drug. It is the first and only FDA-approved once-monthly treatment to reduce the frequency of VOCs in sickle cell disease. So when a patient, after we discuss it with a patient who is a patient who has a lot of acute pain episodes, what we do is we start an initial dose at week 0. Then they get another dose at 2 weeks, and then they get monthly doses after that. This is only approved for patients 16 and older, which is great. Of course, we definitely see that pain tends to kind of ramp up as patients get older, and that teenage years are usually a time when we see a lot of frequent pain crises. But we also have a lot of patients who are less than 16 who also have a lot of pain. So it would be great if at some point we can get this drug approved for those patients as well. We have a couple of patients in our clinic who are taking the Adakveo, and then we also have some patients on the adult side who are taking the Adakveo. And there are lots of patients who report that it works well. Some patients that don't necessarily get relief from the Adakveo. So we're really still trying to figure out the appropriate patient to put on this new drug, but we're excited to have it and see how it works for our patients. The other new drug is Oxbryta, and you can see this paper was published in 2019, so this is fairly new as well. And the mechanism of action for this drug, next slide. So this drug actually binds directly to the patient's hemoglobin, and it increases the oxygen affinity for in that hemoglobin molecule, which in turn reduces that polymerization that Jennifer talked about, that sickling of the red blood cell. And so in doing that, we kind of, the drug basically prevents some of the complications that we see from that sickling in the red blood cells. What's interesting about this drug is the main indication that they studied it for was to improve hemoglobin, so improve hemoglobin by 1 gram. They didn't study the drug's effect on pain. So right now, the current indication is to use it on a patient whose hemoglobin might be on the lower side. Next slide. So when they studied the drug, they did show that people who were on Oxbryta had a 1 gram increase in their baseline hemoglobin. And then when looking at markers of hemolysis, they also saw a decrease in the indirect bilirubin, and then a decrease in the reticulocyte count because hemolysis is quieted down, and there doesn't need to be as a robust response from the reticulocytes. We do have patients in our clinic on this drug. It's a once daily drug. It seems to be tolerated well. We do see some patients with side effects that include like stomach pain or rash. And still, again, trying to figure out the best patients to put which patients are the best to use Oxbryta in. We tend to go for our patients who tend to live at lower hemoglobins in the sixes and the sevens. And we're hoping that, that it does have the effect that the studies show. And then hopefully that this drug will also be studied to see if there's an effect on pain. Just because of the mechanism of action, you would assume it does, but it would be nice to have that data to support that as well. Gnrh is a little bit older. It is basically pharmaceutical grade L-glutamine and is used as an antioxidant. So we do know that hemoglobin tends to sickle under stressful situations like lack of oxygen. It comes in a powder form. And I have to say that I don't think we've seen the greatest results with Gnrh. I think, at least for our practice, we don't have that many patients on Gnrh anymore. And it's kind of fallen out of favor with, overall, and this is not used very often, but it is available if a patient is, or if a parent or a patient is interested. Other new exciting stuff is gene therapy in sickle cell disease. And this is, of course, exciting because this is curative therapy. There are currently 2 trials looking at gene therapy in sickle cell disease. Bluebird Bio is the company that has been doing this the longest, and they've had several iterations of their trials. I'm not going to go too deep into the mechanism and how it's done, just because that's kind of not my wheelhouse. But basically, with Bluebird Bio, a patient's stem cells are removed either through the bone marrow or peripherally, and then they're treated with a RNA-like virus that has DNA encoding normal hemoglobin, and then that is then infused back into the patient after they've had a cytoreductive chemotherapy regimen. The results that are coming out from that trial are really promising and showing that patients can be cured with this gene therapy. Unfortunately, the trial had to close recently because of some poor outcomes that they're concerned may be related to the trial. So a couple of patients developed AML, and then another, I think 1 or 2 patients developed myelodysplastic syndrome. So we're hoping that study can be up and running because it eliminates a lot of problems that we have with bone marrow transplant, which we'll talk about a little bit later. And then CRISPR also is a gene editing tool it's now being studied as well. They have 2 types, a knockout where they turn off the gene that turns off fetal hemoglobin expression, and then a knock-in where basically they're giving the normal hemoglobin, or putting the gene in for the normal healthy hemoglobin. And again, these things are showing good results as well. But this study was also stopped at the same time that Bluebird was stopped. So hopefully things will get up and running, and we'll have some more curative options for sickle cell disease. And then the old tried and true therapies for sickle cell disease. Hydroxyurea has been holding us down for 30 years or so. It was approved in 1988, and it goes by many names. You might hear patients call it Droxia or Hydrea. There's a newer form called Cyclos. Basically, the mechanism of action is to increase fetal hemoglobin. And so because hemoglobin's like a pie, if you increase fetal hemoglobin, then you decrease hemoglobin S. It works very well for decreasing pain, acute chest, and organ damage, and then reducing hospitalizations. It is a once daily medication. The main side effect that we worry about is myelosuppression. So we do monitor our kids pretty frequently when they're on hydroxyurea to make sure their counts aren't dropping. And we escalate the dose over time to the maximum tolerated dose. So you'll see some patients who are on small doses and some patients who are on really large doses, depending on what they can tolerate. And this is a drug that we can keep people on lifelong if they're willing to be compliant with it. And then bone marrow transplant is currently the only definitive cure for sickle cell disease. We do have patients who do opt for bone marrow transplant, and we have good results, but of course it's not without its complications and associated mortality as well. Sometimes we do have trouble getting buy-in from patients because of the possible side effects and mortality. And then there's also the major barrier to getting a bone marrow transplant is finding a donor. So a lot of our patients don't have full siblings, they have half siblings, or we can't find a patient on the registry that matches them. So I would say that's by far the biggest deterrent to getting a transplant at this time. Next slide. So then also wanted to touch on mental health and sickle cell disease. We are realizing now that mental health really plays a big part in the trajectory of a patient's sickle cell disease. And so we want to try to address any concerns for mental health as soon as possible and get them the treatment that they need. So we do know that people with mental health disorders have more admissions for pain crises, they have longer stays in the hospital, and really that there's like a feedback loop between low mood, depression, and anxiety, and how bad their perception of their sickle cell is. And so it's really important that we start recognizing this early in patients to kind of hopefully change that trajectory for patients who do suffer from mental health illness. Next one. Some of the more common ones that we see in sickle cell disease are adjustment disorder, major depressive disorder, generalized anxiety disorder, and post-traumatic stress disorder. I would say of the two most common ones are major depressive disorder and generalized anxiety disorder we see in our patients. So what do we do in our clinic to kind of help with that? So we encourage early engagement with mental health professionals. We do have a psychosocial team embedded in our clinic, and we have psychologists who are available to see our patients and their parents if we identify a patient that may be suffering from some of these issues. We do prompt referral to a psychiatrist for medical management as necessary. That does come with its own barriers, just finding people in the community to actually get our patients into. And then we do mental health screeners in clinic as well to hopefully catch any of these illnesses early and start treatment early. And then transitions in sickle cell disease. So this is an area that has kind of gotten a lot of attention recently, as we're noticing that the transition from pediatric care to adult care is just not as smooth as we would like. We lose a lot of patients during that time. They don't follow up with their adult providers, and then they might show back up a year or so later in really, really, really bad shape. And not just for sickle cell disease, but for any person who is suffering from a chronic disease, we know that this is a major problem. So a successful transition is basically the purposeful planned movement of adolescents with a chronic medical condition from a child-centered model to an adult-oriented healthcare model. And that could be really hard because as a child, you have your parents advocating for you. You don't necessarily have to make decisions on your own, but when you move over to the adult side, then there's this abrupt change to, okay, you're 18 now, you're making your own medical decisions, mom can't be involved. And a lot of kids have no idea how to handle that. They're just not ready for that. And so we want to make that transition as seamless as possible. The other thing to think about with transition is that as you age, what you need as far as your sickle cell disease changes. So like Jennifer talked about with the babies, it's mostly routine vaccinations, making sure they're developing well, seeing their pediatrician. There's usually not a lot of complications just from their sickle cell disease that we see in these patients. As they get older, more school age, then we can start to see more of those complications, pain. We can see some cognitive issues, and they might start to need to be on more chronic medications or more hospitalizations. And then once you get to the young adult stage, we see that this is a time of increased mortality and morbidity. We're not quite sure why, but we can see patients who were perfectly fine as young children, and then all of a sudden they hit 15, 16, 17, and they're falling apart. They're having more pain. They're having mental health issues. And it kind of leads them on this really poor trajectory. And so we're not quite sure what's happening there, but we do know that that's the time that we really need to focus on to help kids kind of understand their disease, learn how to manage their disease, learn what triggers they have, so that they can better take care of themselves. And then again, that's why this transition is so important, because you have a patient who might be deteriorating, and then we're also moving them towards transitioning to adult care, and it can be very overwhelming. So there are lots of studies, and we're involved one here at VCU to kind of create better transition programs to help avoid some of those issues that we're seeing, and hopefully provide better care for our patients as we transition them on to the adult side. Next slide. Again, some of the challenges with transition, there's really a shortage of adult providers in sickle cell disease. Unfortunately, it is not an area that a lot of people are interested in, and some places don't even have any adult providers at all. And so there's no one necessarily to transition them to, which is very unfortunate. So a lot of people get lost to follow up because of that. And then there can be poor communication between the pediatric side and the adult side. So there might not be good handover. We might be sending a patient over to the adult side, and the adult team has no idea this patient's history and what they might need. So we do work hard at VCU to communicate with the adult team about all of our transition patients to make sure they know, what they might need as they transition over to the adult side. And then the same goes for conveying their medical history from the pediatric side to the adult ER. There is a huge model change from pediatric ER to adult ER, where on the pediatric side, our kids are seen quickly. They get their pain medicines quickly, but unfortunately on the adult side, that is not the case. And sometimes patients can be sitting in the ER for hours before they're actually taken care of. And it's a huge shock to the system for a lot of our pediatric patients, even here at VCU. And like I said, treatment lapses and discontinuations just because they're not comfortable with what's going on the adult side. They don't understand how the adult side works, so they just don't come, which is obviously not ideal. So this is the last slide. I also wanted to talk about the transition in providers' perception of patients with sickle cell disease, specifically around pain. And this is an issue that a lot of patients will, bring up with us about how the providers are treating them and treating their perception of their pain. So in the pediatric world, people tend to be more empathetic and sympathetic to little children in pain, and they're more receptive to their complaints. They're willing to provide them with pain medication, and they provide care with empathy and sympathy. What we're seeing is that as they switch over to the more young adult stage, where kids' disease might be worsening and they might be in the hospital more, providers often will become more skeptical about providing pain management. They are uncomfortable with what they consider a lack of expression of pain in these patients. And so they feel like they are inappropriately asking for pain medicine, and then they're less empathetic towards their pain. And that creates a lot of discomfort in the patient because they can sense those changes. I used to come in and it was never a problem, and now I'm coming in and people are questioning me like I'm a drug addict, and it makes them very upset. And that gets even worse as they transition over to an adult. On that side, then they're labeled pain seekers, then they're considered to be addicted to their opioids and using them inappropriately. There can be a refusal to provide pain medication to these patients, especially in the ED. And then there can be some people who treat these patients with disdain and distrust. And this just creates a kind of negative feedback loop in general. So if you have provider bias, the patient loses trust in the provider is less engaged because they feel like the patient is not listening to them or respecting what they're saying. And then the patient becomes even more less engaged. And it's just not helpful for the patient or the provider. The patient is usually not getting the care they need. And sometimes they'll just go elsewhere. So this is a topic that's been well written about provider bias and sickle cell disease. I encourage all of you guys to read about it. We all have our own biases. Even I sometimes as a provider have to stop myself and say, wait, just because they're not writhing in pain does not mean that they're not actually having pain. This is someone who's used to living with pain and has developed coping mechanisms in order to deal with that. So I think it's important for us to think about that as we're providing care to these patients as they're aging in the system. Okay. So that was my last slide. So we're happy to take any questions that you guys may have.
Thank you, ladies. Appreciate it. I've got one question in the chat already. So this one is, please clarify which categories of sickle cell patients required rapid intervention for fever.
So all patients with any genotype in sickle cell disease require rapid evaluation for fever. We consider it an emergency whether or not they have homozygous SS disease or S beta plus disease. So they still need to come into the hospital with the fever of 101 or greater and get the antibiotics and other workup as needed, as Jennifer discussed.
Excellent. And my next question is, what are the best ways for a community pediatrician to help support the sickle cell team in taking care of their patients?
So I think one way is, like we said, from the baby stage where they need frequent immunizations and stuff, just making sure that our patients are getting the immunizations that they need and that there aren't any lapses in those. Making sure you can even do a med rec with our patients. So, if you notice that they're on hydroxyurea, you can say, are you taking your hydroxyurea? Or why aren't you taking your hydroxyurea? And that way you can, contact, or you can relay that information to us and we can better help kind of troubleshoot those things. What else? What do you think, Jennifer?
I think one other thing would be sometimes patients disappear. They are used to their pediatrician and maybe like you guys better than us. I don't know. So have them come back to see us, call us. We have our nurse navigator. We want to see our patients. We want to make sure they're getting the care and the education that they need. But we have had a couple of folks disappear for a couple of years. And then the pediatrician sees and says, have you seen your sickle cell doctor? And it's always great to have them back. So I think that's one way. Just communicating if you are seeing patients, if they're having a lot of complications or things like that, and just letting us know what's going on if they're reaching out to you.
Excellent. And how about, are there any cognitive deficits sickle cell patients can have, even in the absence of a history of stroke?
Yes. So one of the, we actually have educational consultants kind of embedded in our clinic as well, because we do know that quite a bit of our patients will have some trouble and difficulty in school and will need special IEPs or 504 plans to help them be successful in school. We think that one of the reasons that could be is just the chronic anemia that they have to deal with and just not getting the oxygenation to the tissues like they should, could possibly lead to some of those cognitive developments or deficits. So super important to recognize those early in our patients so that we can get them the help that they need and hopefully, get them to be as successful as they can in school.
We do talk a lot about school with our patients just because there's also kids are having more frequent absences when they're sick. And so they're missing more school. So even if they don't have neurocognitive deficits, they're just getting behind just by the sheer amount of school that they may miss. And so I think that combination just makes it really hard. The sickle cell population overall has a very high rate of our patients that have been held back or failed. And so, we're playing catch up sometimes. So we do neuropsych testing within our clinic with our psychologists. We do refer quite often and frequently for school concerns. And so that is something that we take very seriously and do try to help with.
Thank you both. Here's a comment from Dr. Smith. Excellent presentation and lots of new information. Thank you. We also have Teresa LaMonica says, excellent overview from both of you. Transition from peds to adult practices and ED, similar to CF patients seen for years at other children's hospitals. Mm-hmm. Let me see. Can you address sickle cell traits risks in athletes? Great question.
Yeah. So there are actually now a lot of people who are looking more into sickle cell trait as maybe not being as benign as we previously thought it was. We do have some studies showing that patients with sickle cell trait who are athletes can have a risk for sudden death. So definitely something that's still being explored, and we're trying to understand some more, because we know that sickle cell patients with disease can have like cardiomyopathy and things like that. But I think that there needs to be some further research into sickle cell trait and what that might be doing to the heart as well. We do know that patients with sickle cell trait can get infarctions in their spleen, when they maybe go at high altitude and things like that. That's not uncommon. And then we do know that there's actually a special form of cancer that patients with sickle cell trait can get, called renal medullary carcinoma, which is a very deadly disease. So there are some things that we're seeing with patients with sickle cell trait that say maybe we should be focusing on this population a little bit more and not saying you're fine, you don't need to see us at all. So I think some things will be changing in the future.
And I will add, with the sickle cell trait education, there's a great, like CDC has a sickle cell toolkit, and they have a lot of great stuff on sickle cell trait, and they have like get athletes back in the game, and they have stuff for coaches, they have stuff for parents. And I think that those handouts are really helpful when we see patients with sickle cell trait in clinic and doing some of that education. So just check out the CDC's toolkit. I found it to be very helpful for families.
And it looks like this might have been a little add-on. Contraindications with CV vaccine for adolescent sickle cell patients.
CV vaccine?
The CV vaccine. So it's related to the transition from peds to adult practices and ED, similar to CF patients seen for years at other children's hospitals. And it says, and contraindications with CV vaccine for adolescent sickle cell patients.
Maybe coronavirus vaccine. We are recommending that all of our patients get the coronavirus vaccine. We haven't really, there's some, not on the peds side, we haven't really seen that coronavirus has, adversely affected our patients as much as we had worried about initially. On the adult side, I think there are some patients who have had some pretty poor outcomes from COVID. But for right now, we are encouraging all of our patients to go ahead and get the coronavirus vaccine, just because we aren't completely sure what COVID can do to a patient with sickle cell disease.
Yeah, and it looks like, thanks for clarifying in the chat, she was referring to the COVID vaccine. Okay. So thank you so much. I apologize. Sometimes I don't read between the lines very well, but thank you all. Anything else that you'd like for our folks to take away today? Anything major, the biggest things, some hitting the highlights as we wrap up?
I think the biggest thing to take away is just, communication. More communication is better than no communication. We are super open to talking to our pediatricians because, for a lot of care, it kind of goes hand in hand. And if you're seeing things or picking things up that, maybe we aren't because we're not seeing them as often, please feel free to reach out to us. If you have a question or you're concerned about something, we are here to help. So please feel free to reach out to us. Sickle cell disease is a very complex disease, and as many eyes and ears that we can have on these patients, the better for them, so that we can take the best care of them. So I think that would be my biggest takeaway.
Awesome. Dr. Elamine and Jennifer, thank you again. We are right at the end of our Q&A session, so we're now going to take another 10-minute break, and we'll return for our final presentation by Dr. Stephanie Crew, and that will begin right at noon. So stretch your legs again, grab a refill, take a bio break, and we will see you in 10 minutes. Thank you. Right. Welcome back, everyone. I now have the pleasure to introduce our final speaker of the day, Dr. Stephanie Crew, who'll be presenting on sexually transmitted infections. Dr. Crew is an associate professor of the Department of Pediatrics and serves as the Division Chief of Adolescent Medicine. Her clinical expertise focuses on adolescent health and development, adolescent reproductive health, the care of LGBTQ youth, and adolescent obesity. She serves as a faculty preceptor to medical students, residents, and pediatrics, combined internal med peds, as well as child and adolescent psychiatric fellows. Dr. Crew, we're excited to have you here today, and I will hand it over to you.
Excellent. Thanks, guys, for having me. I'm very happy to be here, happy to bring up the rear at this conference, and happy to hopefully impart and review some information that primary care physicians can take away today. So we decided to focus on sexually transmitted infections. Apparently, primary care physicians want to know more information about this, and so we're going to bring it to you live. So again, happy to be here to interact with you guys as much as we can virtually. So we're going to talk about sexually transmitted infections, which remains a significant source of morbidity among adolescents who unfortunately bear a very disproportionate burden of disease. Sort of in the wake of the global pandemic, we as providers were really challenged with dealing with two concomitant public health crises simultaneously, both of which required innovation and consideration in terms of how services were accessed, how we stratified who we saw in person versus who we saw virtually, and how we optimally manage symptoms and sequelae of these two concomitant health threats. I have no relevant disclosures, and I don't intend to discuss any unapproved use of any products or devices in this presentation. So this is unfortunately the other public health crisis that we have going on. Certainly COVID-19 is a time of heightened health, social and economic stress and insecurity, and it really necessitated a rapid and critical shift in healthcare access as well as healthcare delivery. It also unfortunately highlighted the breaches, highlighted where there are significant gaps, and highlighted where there are certainly some poorly acknowledged inequalities that absolutely exist. In that shift, public health resources that really previously supported sexually transmitted infection care and treatment and prevention shifted so that we could spend more attention paying attention to the pandemic. And this in and of itself exposed a very vulnerable public health infrastructure. It affected in-person STI treatment, in-person testing, and even being able to provide preventative strategies and preventative sexual and reproductive health services for teens as well as young adults. I look at this, the perfect storm that was created in seeing that lockdown mandates and irregular schedule, not having a lot of adult supervision or oversight, and certainly social isolation created this perfect storm and perfect combination to really increase sexual risk behaviors among teenagers. There is already a significant difficulty in mitigating inherent risk associated with intimate contact, but this actually intensified, and it further revealed that we have a long way to go, and there indeed is a rising tide of sexually transmitted infections in this population. I think at the same time, it sort of dispelled some of the assumptions. So some of the assumptions were that lockdown was going to keep everybody apart and we wouldn't really have to worry about STIs rising at all. But in fact, that has proven over and over again to not be the case, as far as we're seeing that STIs are on the rise instead of going on a decline now that we're kind of getting our head above ground in terms of the COVID pandemic. So today, we're going to focus again on risk factors associated with sexually transmitted infections, particularly among adolescents. We're going to focus on some clinical findings and treatment recommendations of some common STIs. And then we'll discuss lastly some strategies that really help us to provide effective and sensitive care to kids, as well as some prevention services. So I'll go through some screening practices that we are applying to adolescents as well as young adults to help the primary care provider and anyone taking care of teenagers to be effective in delivering this type of care. So what does it look like? Globally, it looks very, very a daunting task that we're faced against, and a daunting challenge. In the US, we continue to have some of the highest rates of sexually transmitted infections compared to any developed country. There are about 20 million new cases of sexually transmitted infections each year in the United States. And unfortunately, 15 to 24-year-olds, although they only account for about a quarter of the sexually active population, they actually account for 50% of the new STIs that occur in the US. About 1 in 4 sexually active teens has a sexually transmitted infection, and most are also asymptomatic and undiagnosed. Unfortunately, this leads to poor outcomes. If it's undiagnosed, then it can lead to adverse reproductive health outcomes, such as infertility, severe pelvic infection or chronic infection, chronic pelvic pain, certainly ectopic pregnancies, and worst of all, increasing the risk of HIV transmission. So we look at adolescents and we ask the question of why do they face this disproportionate risk for STIs as presented in the last slides. And so we kind of break these or stratify these according to these 4 larger categories of risk factors, such as biological risk factors, developmental and cognitive risk factors, behavioral risk factors, as well as socioeconomic risk factors. So we'll talk about each of these individually in order to give us a better picture of what's going on. So certainly cervical ectopy plays a unique role in teenagers. This refers to columnar cells that typically are found within the cervical canal. They're actually located now on the outer surface of the cervix. Now, this is quite a normal finding in adolescents as well as young adult females. However, what is useful to know is that these cells that are now on the outside are actually very sensitive and actually very much more susceptible to infection compared to squamous cells that are found when ectopy does not exist. Also, there is lack of immunity from prior infections, as well as smaller introitus, and this increases the opportunity for traumatic sex, as well as increases the opportunity because of that traumatic sex in exchanging body fluids more readily. And moving to developmental and cognitive risk factors, we see that there is certainly, the younger you are developmentally, the more you're going to have more of a concrete thinking mindset. And with that, you have a lack of cognitive maturity. Having concrete thinking contributes to denial of risk. I don't think that I'm at risk. I'm not vulnerable to this. This happens to everyone else, but it doesn't happen to me mentality. So that weighs into, again, them facing this disproportionate risk. Thirdly, we have behavioral risk factors. We know that kids that actually have sex before the age of 15 are nearly 4 times as likely to report a bacterial sexually transmitted infection in the past, and they're more than twice as likely to report pelvic inflammatory disease as compared to women or females that actually had their first sex after the age of 18. Certainly serial monogamy, so maybe being in a relationship with a partner for a 3-month period, but also the next 3 months having another partner and another partner. So before the end of that year, they've had anywhere from 4 to 6 partners. And we know, again, the younger you are, the more likely you're to have that serial monogamy as a part of your sexual history. incorrect and inconsistent condom use. So in clinical practice, I always go through, well, how is the condom being used? Is condom a part of the sexual act or is it not? Certainly, it's, how you take the condom out the wrapper, but certainly it's when do you place the condom on? I have some kids that will tell me they place the condom on right at the beginning, and then at the end of sex, they take it off before they ejaculate. So you actually have to be very mindful with the counseling piece of this, of counseling them on correct and consistent condom use. The consistency comes in the picture when they say, I only use it with the ones I only use it with the ones that look like they have something going on, or I only use it with the ones that I don't trust. So we need to emphasize to them, no, it needs to be with every partner that you have, whether it's a long-standing partner or new partner, emphasizing that to them. Certainly, concomitant use of various substances, including alcohol and drugs, could be a behavioral risk factors. And we also have found that older partners lend to power imbalance, which then leads to difficulty in sexual negotiation. So that would be sort of that category of behavioral risk factors. And then we have these socio-environmental risk factors, which could be culminated into ineffective public policy. And the first thing I always say is the adolescent health field, or adolescents in general, even on the public health policy agenda? Because that will then impact what public policies are made. It will impact things like the effective or adequacy of access to even confidential health services for teenagers. Another thing is sort of community characteristics. And when I think of community characteristics, I think of what is the sexual network composed of, and describing what that sexual network, and when I say that, who are these kids having sex with, and what is the concentration of sexually transmitted diseases within that particular community or that particular population. We also look at things like socioeconomic status. We know that poverty is a huge risk factor. Disadvantaged populations or kids with unstable living conditions, that may be a significant environmental risk factors. So all of these factors individually or in any combination thereof really creates the perfect forces for the perfect storm in a very developmentally vulnerable and transitional period. So we'll now hop right into sort of the meat of it all, and talking about sexually transmitted infections. So we can't obviously talk about each and every sexually transmitted infection. So we'll just kind of hit off on the most common. And certainly if you have questions about something that we don't see as often, we can save it for chat. But I broke this down into those that are characterized by abnormal discharge, urethritis, or cervicitis, those that are characterized by genital lesions, those that are characterized by ectoparasitic infections, those that are characterized by anal genital warts, and then we'll have a special considerations category. So if you are eating lunch, I'm going to show some pictures. So if you're not the world's best person to kind of hold it all in, just pause your lunch for a couple minutes, because we're going to have some pictures just to illustrate how some of these infections present clinically. So we will start with what we call trick, and what's known as trichomonas, which is caused by a parasite called Trichomonas vaginalis. Generally, what I usually tell most people is that most kids are asymptomatic. Many have minimal symptoms, or they actually don't have any symptoms at all. But if they are symptomatic, if they do show up with symptoms with trick, usually males are going to come in with some sort of pain with urination. Sometimes they can come in with frequency of urination, and some can come in with either painful ejaculation with blood in their urine or their semen, or just saying something is not right. Females, we typically will see, if we're going to see symptoms, they're going to have a malodorous yellow-green frothy discharge, and that can have irritation at the vulvar area, inflammation at the vulvar area. It can also present with dysuria as their primary symptoms or intense pruritus. Obviously, the differential can include Candida infection with the pruritus being there and the description of the discharge. However, if you are thinking that this kid is sexually active or they tell you they're sexually active, you need to keep trichomonas on the radar. NAT testing is the preferred nucleic acid amplification testing is of the urine or vaginal secretions, is sort of the most sensitive testing that we're doing right now. The sensitivity is between 95 and 100%. Certainly that beats out cultures and wet preps, as many of you, if you've been practicing probably in the 80s, 90s, wet preps were taking over as the standard, but we were missing a significant number of cases because the sensitivity is much less. If you were to do a speculum exam, these pictures would highlight some of the findings that you might see. Certainly the first showing that frothy, sort of looks like you shook up a can of soda, and sort of that was the remnants of that frothy discharge. And then the second picture, which is showing your cervical os in the middle, here, as well as this would be the cervix. You see these little punctate hemorrhages that are on the cervix area, and that would suggest punctate hemorrhages. And it's sort of one of those telltale signs of trichomonas, also known as a strawberry cervix. Recommended regimens are pretty easy to do, as well as easy to prescribe. If you have it in the office, great. If you don't, it's very easy to send in a prescription for it. Metronidazole, 2 grams, 1 single dose. One of the things that we know about recommended regimens in teenagers is that on-site treatment has the best outcomes for adolescent patients. The less you can get them to remember, the better outcomes you're going to have. Tinidazole, 2 grams in a single dose, and an alternative regimen is metronidazole. You can still use that. So sometimes what I'll have is that I'm thinking whether or not this kid is facing bacterial vaginosis with the malodorous smell and the discharge they're describing, or is it trick? And I'm still waiting on both of my tests. So I kind of go for the lesser 2 evils because they've said, hey, I'm also, using this new soap, and I haven't had sex in a while. I probably will start them on 500 milligrams of metronidazole twice a day for 7 days, which is both a treatment for BV and could potentially be an alternative treatment for trichomonas. So in the end, if my BV is positive, then we're going to keep them on that regimen. If that is negative, but my trick, and then I'll give them the 2 grams of metronidazole and wouldn't continue because they probably wouldn't finish out that course anyway. Another presentation of vaginal discharge, urethritis, or cervicitis sort of comes in the form of chlamydia trachomatis. This is the most common and continues to be the most common commonly reported bacterial STI that we face. It too is usually asymptomatic, and this is usually the reason why there's so many high rates of transmission and subsequent infection with the particular bacteria. Again, NAT testing is the preferred method of choice from the urine or the genital site in question. You can either get a first void urine. So usually say the dirtier the better. So that first urine void is great. If the male is saying, I do have a discharge, and you examine him and you can see the discharge, you can just take a sample of that discharge and send it for NAT testing. You don't have to do an intraurethral swab that used to be done back in the early 2000s, probably 90s, 80s, where you were actually taking the specimen and collecting it by going into the urethra. That's no longer needed. So if they do not have a discharge or saying they don't have a discharge, just grab a urine and you'll be okay. Treatment is to prevent adverse reproductive health outcomes, which we talked about before, but we'll talk about in another slide later on, the complications that may be associated with ongoing or chronic infection. And also it decreases transmission to their sexual partners. What I will say is, and why I put that star there, is certainly some people always want to make sure that it's gone. So they'll say, so can I come back next week and make sure that the infection has gone away? Or can I come back in 2 weeks? Or when do you want me to come back to make sure that it's completely gone away and it's cured? Usually we do a test of reinfection rather than a test of cure. So a test of cure is really detecting whether that's been therapeutic failure. And that's really not advised for persons that are treated with the recommended and alternative schedules that we have. So usually testing in a certain time period, because of the type of test, which is very, very sensitive and tests for both dead and alive organisms. If you do it too early, you're going to get into the habit of having all of these false positives just come back and forth because you're testing too early and you're actually picking up dead DNA as opposed to an active infection going on. So generally, we'll tell them to come back in 3 months and we'll test for it. We'll do a test of reinfection rather than a test of cure. The only time that differs if maybe you have a pregnant teenager and you want to ensure, in order to decrease the likelihood of adverse events with regard to that pregnancy, I may have them to come back in a month or 6 weeks just to make sure, but nothing under the 4-week mark. I think you'll just be chasing your tail in terms of positive results. The recommended regimen, again, that single dose regimen is probably the best for most adolescents. I've had the opportunity, some kids don't have insurance, and so they just want to kind of pick up their azithromycin from the store. It costs about, what I found is it costs about $40 for that regimen of azithromycin 1 gram PO. But some people are willing to pay that price if they don't have insurance. If they do, this is certainly covered by insurance, so you can just send that in. And direct observation obviously is preferred. And just practical pieces is I usually will have them to eat before I give them the azithromycin. Otherwise, they're going to have some GI turbulence or GI distress, and they're going to actually have some nausea and perhaps even some vomiting. So I'll tell them to eat before that. And then doxycycline can also be used. Again, that's an extended regimen. So most times kids are going to say, yeah, I didn't finish that out because I felt better on day 3. So they left the rest in the bottle that's now in the trash probably. So if you can do the 1 dose, do that. If you're left with just the doxycycline, that is the dosing regimen that can be given. Symptoms, again, like we said before, it's important to note that up to 80 to 90% of these kids are asymptomatic in terms of females, and up to 90% may be asymptomatic in males. And so when you are in clinical practice, a lot of the times, if one partner comes in and they're diagnosed and they get treated, they have a hard time convincing their partner, who is also asymptomatic or maybe asymptomatic, that, hey, you need treatment as well. But I think as a part of the counseling of that patient, the patient that we know is affected, telling them about the fact that their partner still has to be treated, whether or not they're actually having symptoms. Females, one of the common things, in addition to vaginal discharge, if they are symptomatic, that they do have, I'll see a lot of spotting, particularly if we have them on another method of contraception, such as Depo-Provera. They have been stable in a Depo-Provera dose, but all of a sudden they're having all of this spotting or all of this irregular bleeding. And even if not on Depo and they're on some other method, you may see some breakthrough bleeding, and it's usually related to the cervicitis or the inflammation of the cervix that's going on. Certainly other things, pain with sex, dysmenorrhea, when you start having those things, you start thinking more and more about, has this surpassed the cervix, and is it going into the upper reproductive tract? Males, if they're symptomatic, again, may show with penile discharge and dysuria as the primary symptoms with chlamydial infection. Gonorrhea, another heavy hitter and probably the second most common and is the second most common STI or bacterial STI in the US. Most, again, are asymptomatic, unfortunately, and the causative organism being Neisseria gonorrhea. They could have, again, all of those symptoms that we've talked about before and that we'll mention on the next slide, but diagnosis is also through NAT testing. Sometimes you can get combination testing, so it actually tests for both, but be sure whatever lab you're sending it to, you don't need to put in 2 individual orders for gonorrhea and then 1 for chlamydia, because usually you're checking for both and not just one. Sometimes they're co-infected with the other. And so you want to make sure that you're checking for both when you're doing that testing. Old school 80s, 90s, and early 2000 of the chocolate agar cultures is not the state of where we are right now. NAT testing is a #1 winner because, again, the sensitivity is just so much better. So, yep, in the midst of a pandemic, there were recommended changes with regard to how we treat gonorrhea. And a part of that is the ongoing threats that are associated with emerging gonococcal resistance, which has been in effect for a decade or more now with the emergence of this resistance pattern with gonorrhea. But that wasn't the only thing. The resistance, I think it was also partly due to access to intramuscular injection, because a lot of the places that provided these services, including primary care physician's office, were closed for in-person visits. Also, and that was more with the alternative regimens that came up. Another thing that came up during this pandemic and probably shortly before was the shortages in azithromycin. So it's a national drug shortage, which still exists, of azithromycin, which made them, again, look at a new recommendation. So between the time that I started residency and now, we've gone through at least 3 changes in the recommendations for how we're treating gonorrhea. So right now, as of today, as of December of 2020, ceftriaxone 500 milligrams in a single dose is the recommended regimen. Alternative regimen, and this is for uncomplicated gonorrhea. And if ceftriaxone is not available. So you can use either gentamicin, or that's an IM injection plus the azithromycin, or you can use an oral dose of cefixime as a single dose. If you're using that cefixime, most people are going to say that if the patient is still symptomatic, you want to get another sample and retest them to ensure that infection has gone away and it's susceptible to the cefixime. Otherwise, we have to make an arrangement for that patient in some way, shape, or form to get the IM injection of that medication. Treatment for co-infection with chlamydia. So sometimes you're seeing the kid in the acute setting. It's recommended at this time, if you do not know whether or not they have the chlamydia infection and it hasn't been excluded, then one thing you can treat them with, in addition to the ceftriaxone 500, is doxycycline 100 twice a day for 7 days, which has ruffled a couple feathers, again, with the mindset, if this kid, for example, is coming into the ER and you don't know yet, and you're giving them their iron injection, is the kid gonna finish off the doxycycline? What if you can't get back in contact with them? If they need to finish off that infection, will they complete that and adhere to the regimen as you have stated? And you're going to send them with a prescription, so are they going to even pick it up is another question. So but these are the recommendations as they stand now. So sometimes in the ER we can get rapid results back, but sometimes you can't. So in clinical practice, this is the recommended sort of tread that we should go. I've really reiterated this again, but again, about 50% of males and females are not symptomatic, but if they are, sometimes this shows up as a yellow-green discharge, pain with urination, and sometimes with sex, females can complain of pain with sex or bleeding with sex, again, with the cervix being affected most. Again, with males, same thing. They can have purulent discharge from their penis or pain when they're peeing, or even if it's advanced, they can present with like an epididymitis with swollen and painful testes, which will make it now a complicated GC infection. So I often say that epididymitis to the male is almost like PAD to the female, so you should treat it as such. Moving on to genital ulcers, and in my brain, we'll go through each of these individual, but sometimes I find solace in looking at charts to really compare the diseases that present very similarly, such as these with genital ulceration. So we'll go through herpes, we'll go through syphilis, and we'll go through chancroid. Now, chancroid is not, I wouldn't say common, but I think that it's a rule out that we need to be aware of as primary care physicians, especially as you go into that young adult population. It depends on where your cutoff is, but if you're taking care of up to 24, up to 26, I think chancroid needs to be on your differential when you're presented with genital ulcers. If we look at incubation periods, the incubation periods definitely differ among the three different presentations of these. Certainly, sometimes you can have one ulcer or many. Again, it kind of shifts you into which lane you should be in based on that incubation period, based on how the lesions look and what associations you're having with those lesions. So I'll leave that. You guys have that in your booklet. So I'll leave that and you may can use that at some other time period, but we'll hop right into genital ulcers. So genital ulcers are, when we talk about herpes in particular, that's the one we're talking about right now. This is chronic and lifelong. It's caused by serotypes 1 and 2. There used to be this distinguished sort of, if you have oral lesions or a lip lesion, it was definitely herpes 1, and if you had genital lesions, it was definitely herpes type 2, and that's not the case anymore. We don't kind of say one or the other. Now, certainly you can do testing to determine if you do have a lesion and qualify which type of, or serotype, which type of HSV it is, but it doesn't necessarily clinically look different in terms of how it presents. Certainly, we see more recurrences and subclinical shedding with type 2, but in terms of how it looks, if someone has a genital lesion, HSV lesion type 1 is not going to look much different than type 2 in terms of looking at the actual lesion in the genital area. PCR testing is the preferred test of choice. Sometimes people do use culture, but again, the preferred testing is used most. The culture really, you have to have a new lesion, and you have to, because you have to have a pretty high viral load and for the culture to actually pick up something. And generally, this can show up as these sort of ulcerations, like these very shallow but very painful ulcerations. As you can see, these multiple ulcerations that are here, having a very erythematous and angry base to it. Sometimes there can be like an overlying clear exudate over top of these very shallow, but again, very, very painful lesions. These are more vesicular lesions and can show up like as papules or vesicles here. If I needed to get a sample, I actually would unroof this lesion in order to get a great sample from that lesion. The treatment, which will go on the next slide because there's a lot of recommendations, but the treatment is really based on whether this is their initial episode, whether this is an episodic episode or recurrent episode for them, or whether or not you have them on suppressive therapy because they're having a lot of outbreaks. And one question that I get a lot from patients and occasionally from outside providers is there something I can check in the blood to make sure that I don't have it? So they didn't necessarily present with lesions. Maybe they had sex with someone 5 months ago and they found out that person has herpes, and they just want to make sure that they're okay and that they don't have genital herpes or herpes of any type. Right now, and it has been the case that the CDC does not support, does not endorse, or recommend universal screening with serology testing. So sometimes you just kind of want to quiet, for whatever reason, quiet the parent, quiet the family member, quiet the patient, and just like give in to, okay, I'm just going to do some blood work to make sure it's not there, but it really doesn't give you any guidance if you do get a positive or you get a negative. It doesn't help you to help your patient in any way. So that is not recommended to get serology testing. I usually tell the patient, if you have a lesion, we're going to test that lesion, and that's going to give us more bang for our buck in how we move forward with this. So we're not going to go through obviously every single treatment recommendation for herpes, but again, I like charts, and this is the chart that the CDC has in their treatment guidelines. Certainly, there has been a delay in the release of the 2020 guidelines in total, but I think that they're kind of just doing drops, and one of the drops was gonorrhea. I don't think many things are changing other than that in the treatment guidelines, but the last guidelines are from 2015, and generally acyclovir is your best friend when you're treating this. I think that acyclovir is the cheapest, it's the most readily available, and it's the most covered by insurance companies for the most part. And so again, putting your patient in a category of what is this their first, is this a subsequent outbreak, or if they've had enough flare-ups that you're now ready to start them on suppressive therapy and you feel comfortable in doing so. So I'll leave that chart for you guys to have in your booklet. Primary syphilis, I must say, we're not seeing this in a lot of patients, but it's something we need to be aware of, again, because genital ulcers are genital ulcers, and we need to make sure we're differentiating them and diagnosing them appropriately. Most of the time, we are very aggressive in screening for syphilis with our patients, that men who have sex with men is the top population, that this is the highest sort of rate that we've seen of increase in terms of sexually transmitted infections with that particular population. This presents as a painless, imagine that being painless, but a punched out ulcer that we see, and it does have some raised borders. So this is on the penis, right underneath the coronal surface of the penis, with these heaped up borders. Again, this is painless. And this is sort of usually very small. And so people just say, maybe I got my penis caught up in my zipper and that's creating the sore. Again, this young lady probably could not see this lesion, but knew something was there. Maybe if she was choosing to shave, or maybe she went for an examination. But again, this painless raised border picture, this is caused by Treponema pallidum. You diagnose this, they've had a classic pathway for eternity of diagnosing this. First, you went with a non-treponemal testing, which is through VDRL or RPR testing, which is very, just because you get a false, you get a positive for VDR or RPR, you still have to do a confirmatory test. And that's mainly because the VDRL and RPR testing could be falsely positive because of other infections or vaccines. Sometimes in pregnancy, these can be positive. So it's always necessary to have a treponemal antibody test, which is through the FDA antibody test, or specifically treponemal antibody. So sometimes labs will do a quick reflex if they get a positive, but sometimes you actually have to order both, particularly in outside non-academic labs, you have to order both of them. If that is the diagnosis that you're considering, I would do the non-treponemal antibody test, and then I would also order the treponemal testing as well. The titers, the non-treponemal titers are used to, and they may correlate with disease activity, and they also are used to follow if they're responding to the treatment. We see a full 4 change is necessary to demonstrate that they're demonstrate a clinically significant difference. And so you have to use the same method of, if you're going to do VDRL, you follow VDRL. If you're going to do RPR, you need to follow that. You can't switch up in the testing methods. And it may take several weeks for it to respond after the patient has been tested. The FDA antibody will likely be reactive for a lifetime and shouldn't be used to predict treatment response, just the non-treponemal. Just to know that the Gnrh-Hersheimer reaction is a true reaction that can happen within 24 hours of treatment. It actually will spontaneously resolve. You can use supportive care to get them through, but just to be cognizant when you're treating them with this high dose amount of penicillin, which is still the method of choice for treatment and the only choice that we have in terms of treating syphilis. Usually we'll split this into 1.2 in each buttock, so for tolerance sake, but 2.4 is necessary for the treatment regimen. And chancroid, it's a decreasing prevalence. It's rare in teens. It's caused by Haemophilus ducreae. It requires a special medium. It can present with this painful, so I use the last part, ducreae, because you will cry, but it's a painful genital ulcer. And it can also lead to the suppurative inguinal lymphadenopathy, and scarring can result. It is cured by azithromycin. It is cured by ceftriaxone 250, Cipro, or erythromycin in this recommended regimen here. And this will resolve the symptoms as well as prevent transmission of that. For ectoparasitic infections, we still, every now and then, we'll see crabs pop up. It presents as severe itching in the groin area, and you actually can see visible lice and nits in the pubic hair. You may have some tracking along the skin. Sores and secondary bacterial infections can also present from them intensely scratching the area. These lice do not transmit disease. They are parasites. And all sexual partners within the last month should be informed that they're at risk, and they actually should be treated concomitantly. The recommended regimen, they have been seeing a few cases of pubic lice not responding to one round of the permethrin or the pyrethrines, O'Neill butoxide, sorry, long word, some increase of resistance to that. But if you usually go round 2 with that, I usually will wait another week or 2 before I'll retreat them, because there still may be, again, from just the secondary inflammation, some itching that is after they've been treated. So I kind of wait a little bit to retreat if they haven't responded effectively. And making sure they wash and dry the clothing and bedding used for that infected person in very hot water and a hot drying cycle. Warts, definitely 90% of these are caused by HPV 6 and 11. Thankfully, we have seen a decrease in this thanks to your efforts with HPV vaccinations. So we don't see this as much as when we were all in residency probably, but still something to keep in mind. These are usually asymptomatic, but can be a little itchy for some people depending on how they are. It can be maybe, especially if they're really pedunculated, they can like rip at things and tear easily. So these growths may be painful at times. And we usually just say visually, this looks very wart-like on the genital areas. This one shows these rising plaque-like formations that are very irregular along the coronal surface of the penis. Usually we're going to treat this to ameliorate the symptoms that they may have, but also for the cosmetic appearance of them, and also to decrease transmission to their partners. Therapy reduces, but it definitely does not eradicate HPV infectivity. These may come back, although they also may spontaneously resolve. So it usually with treatment, it depends on the number, how much this is affecting the patient and whether they have significant concerns. You can have patient-applied therapy, or you can have provider-administered therapy. With any of these options, I usually will say it can cause local irritation, it can cause burning, it can cause pain, and it can cause blistering. So making sure that the exact lesion is being touched and not the surrounding skin. But even if it's just the lesion that's being touched with the regimen, it can still cause that irritation and burning sensation. Special considerations, we're going to just briefly mention HIV as a growing problem for this particular population. In 2016, kids ages 13 to 24 made up 21%, so almost a quarter of all new HIV diagnoses in the US. We're seeing significant health disparities with this, with 81% of these new diagnoses being among men who have sex with men that are young. African American and Hispanic populations are affected particularly more. Early diagnosis and treatment, so making sure you're following the screening guidelines, which we'll mention in a second, are essential to patients' own health as well as to reducing disease transmission from one person to another. Treatment options have improved, but certainly drug resistance, stigma are still prevalent, as well as morbidity associated with HIV. PrEP is a big thing for that's on the market and marketed towards those that are 18 years of age. And usually our ID people do a phenomenal job with helping us to facilitate PrEP in those that we think are eligible for that and would be good candidates for that. So keeping that in your mind in terms of who do I send them to if I think that they're a good candidate for PrEP. It's sort of PEDS ID and ID specialists work miracles in terms of getting those kids in. Other considerations are the psychological consequences of STIs and STI diagnosis, which we cannot forget about. That's something that I do very, very often, unfortunately, in clinical practice, is diagnose STIs, but I don't forget that every kid is different and the psychological consequences can be immense. Also, don't forget about some of the after effects or immunological mediated effects of chlamydia infection, such as Reiter syndrome, and also what happens if they go untreated, which is the laundry list of things that potentially could be, again, significant forms of morbidity and long-term sexual health outcomes can be associated with STIs in general. Counseling, knowing the specific STI diagnosis can potentially reduce complications, reinfection. If you know, then you educate. You educate your kid on how to prevent this from happening again, what this STI diagnosis means if it's not treatable, and how to decrease transmission. Again, addressing the psychological strain that might be there. Reinforcing safe sex practices or risk reduction counseling is an immense strategy that we have to incorporate. If we're testing, then we have to be ready to counsel. We have to be ready to reinforce these preventive practices into all the things that we teach these kids. Treatment failure is really usually not the case in teenagers. Like, we give them the medicine, they take it, usually gets rid of. If it's a curable disease, it usually gets rid of it. It's usually reinfection that's the problem. And so we kind of will have to sometimes twist their arm maybe a little bit in saying, if they come back with the same symptoms in a month, say, did you have sex again with your partner, and was your partner treated? And they usually will say, well, I don't know, or no, he or she wasn't treated, and I had sex with him again unprotected. So that's having good rapport with your patients and helping them to, again, navigate a very tricky situation sometimes and disclosing to their partners. Usually I'll say, don't have sex with that partner until they're treated, and 7 days after that partner is treated, then you can engage in protected sexual activity. Advise barrier protection with all sexual encounters, not just those that you trust, but those that that you have sex with all the time, right? But obviously you want to minimize the number of sexual partners, but if you have a person that's kind of all over the place, you want to make sure that you're arming them with the knowledge and information they need in order to protect not only themselves, but the people that they are engaging in sex with. And like we said before, retesting for gonorrhea and chlamydia. Some people are even saying trichomonas, especially if they're still symptomatic, but usually unless they're symptomatic, I won't retest necessarily for trichomonas, but I will for gonorrhea and chlamydia about 3 months after they get treated. We've already talked about the difference between test of reinfection and versus test of cure. And again, reiterating the point, you test too early, you're going to get false positive results. What are the screening recommendations for sexually transmitted infections for asymptomatic? So the screening recommendations are kind of on pause, to be honest, in terms of screening all females less than 25 years of age. And that's because the testing supplies are down in terms of, again, that shift with COVID-19, the testing supplies that would typically normally be used for things like gonorrhea and chlamydia testing are now shifted to providing testing supplies for COVID-19. So we've kind of put a small bit of a pause on just annual screening of asymptomatic young adult females. But once we unpause that button, annual chlamydia and gonorrhea screening of anyone that is sexually active under the age of 25 is recommended. For males, there's insufficient evidence, according to the CDC, to recommend routine asymptomatic screening, but it should be considered if you are in a high risk or high prevalent area, if you are at an STD clinic or even an adolescent clinic or correctional facilities. It's still annual testing is actually more of a risk-based sort of screening practice. So in those, you're definitely more. Any sexually active male who have sex with men, annual testing for gonorrhea, chlamydia, HIV, and syphilis. HIV at least once during the adolescent period is also recommended regardless of risk. And then annually if high risk, and there are currently no screening recommendations for BV, trichomonas, HSV, or HPV in asymptomatic teens. So to end, it still remains a significant source of morbidity among teenagers, particularly at this heightened time of the global COVID-19 pandemic. It still presents a major public health threat and a major public health challenge. There are potential for significant short as well as long-term reproductive health consequences and psychological consequences of these diagnoses. They remain at increased risk for all the factors that we talked about today, including biological, cognitive, behavioral, and social factors. But I think overall, we as primary care physicians are in that unique positions. We know our patients, we know what they need. We just have to be armed with the information, the latest and greatest, most up-to-date information in caring for these teens, and really providing recommendations that are imperative to help reduce the prevalence and reduce the complications and reduce the transmission of STIs. So with that, we're going to end. April right now is STD Awareness Month, so this is right on point with what we're talking about today. Certainly, there are some resources that I found that are particularly awesome for those that are learning, those that are teaching about STDs, which I have listed here, and two of the articles that I think are very helpful for primary care physicians, both at this time as well as for future reference. So with that, I'll take any questions that you guys have as 6 minutes and 30 seconds remain.
Thanks, Dr. Carew. We appreciate you. Great information. The one question that is in the chat right now is, if you give the Cefexime 800 milligrams, when do you retreat?
So you can actually retest in about a month after if
Excuse
they're
me,
still
retest.
symptomatic.
I misspoke.
That's okay.
Retest.
If they're still having symptoms in about a month, you can go ahead and just retreat them. I would try, if they're still symptomatic, I would go ahead and just give them the IM ceftriaxone if you have that available at that time. If not, you can give them the oral cefixime again. And then I would also, before I did it, because I would probably retest them again to make sure it's still that particular disease, particularly if they said I had sex again, I would actually retest them at that 4-week mark. But I will also just in the office or in the prescription, I would just go ahead and treat them and see if that actually makes a difference in their symptoms, because something is missing. Either we've got another infection going on, or they had sex again with that same partner. But the likelihood that the medication didn't work is probably not the real story.
All right, thank you. Wonderful practical presentation. Got some feedback in the chat. So again, thank you. And another question is, how do you effectively manage kids during the pandemic? When do you know when they can have a virtual visit, and when do you feel like they need to be seen in person?
Excellent. So one of the things that was a heavy hitter for us in the adolescent clinic was providing care for kids. And so, we were definitely not a telehealth clinic before. We did very few telehealth visits where our primary care providers were doing definitely more of telehealth than we were. It takes an awesome nursing team and an awesome staff that can triage your patients. And if they're not able to come up with, whether or not we need to actually see them, if they're symptomatic, then most likely we were going to bring them in. But I felt like sometimes it would be a parent of a 12-year-old, for example, that is kind of hovering over her child, and they notice some vaginal discharge that was present. And when I talked to the parent alone, with the patient alone on this telehealth visit and triaging them, this kid didn't even know what sex was, and I'm thinking it's more of a chemical irritation, or maybe even a vaginitis caused by Candida. So for that particular kid, the 12-year-old that's not even had sex, doesn't even quite know what that means. And it's being pretty honest and open with me, and we're actually able to see them. For those patients, I usually would say, okay, let's try good hygiene in the area. If it's really itchy, let's go ahead and try a dose of fluconazole, 150 milligrams, and let's see how they're doing in a week. And if we make changes with hygiene, wiping practices, and treating potential Candida, then I would go ahead and do that. But for the older kid that's saying I'm sexually active, I now have the vaginal discharge, I may even have some belly pain, but I'm not sure, then we were kind of just bringing them in. But we definitely had to do sort of a stratify who needed to be seen and come in person versus who we could handle over the phone.
Excellent, thank you. And then I think you touched on this in the presentation with the updates from the CDC and the guidelines.
Mm-hmm. Yeah, so they hit us with that. It kind of came out of the blue in terms of updates. So we kind of maneuvered. So before, when we did ceftriaxone, we did, I think the latest was we would do 250 of ceftriaxone, and we would do 1 dose of azithromycin when it came to treating gonorrhea itself. And so that then kind of came a swing of, one day I'm doing that, and the next day, because I've been told by the CDC, the recommendations have changed, sort of swinging into the 500. So that kind of came out of the blue, and it was definitely after February when I found out that the recommendations has changed. So kind of just staying up with the latest and greatest has been a little bit more difficult because there are rapid fire changes that are occurring, but still you need to be in the know for what's going to be best for your patients in terms of recommendations that come about.
Excellent. And I'm just we'll take a couple of seconds here as we're winding down just to give folks a last couple of minutes to pop their questions in. But yeah, again, thanks, Dr. Crew. Valuable information for our community partners and just for our patients and taking care of these kids and teens, especially during a pandemic. So again,
we're also just wanted to put it out there that we're always happy to answer questions that come out in the clinical world in terms of your comfort level. So I know that sometimes you may or may not have the time to talk to patients, or you may not have the time to counsel patients, or you may not feel comfortable in doing so. Obviously, we want you to feel comfortable, but if there is a barrier of some type that you need to address, then we already have certain pediatricians that call us, and we're happy to take those calls and discuss the case with you to make sure that we're headed in the direction with the benefit of the patient being the primary priority.
Right. A question: how do you manage adolescent privacy when doing testing and sending out labs? Parents will get the statement if it's through insurance.
Some will, some won't. So you have to include that as well in your discussion with the patient about billing, which has been, the insurance companies are working a lot with us, a lot more in terms of trying to keep statements a little bit more vague for parents. But the obvious thing is you cannot guarantee 100% confidentiality. So in talking with the teen, hopefully you're talking to them by themselves, revealing that as a potential loophole in this thing and whether or not they need to be tested somewhere else. Sometimes if we're I might say that, we're going to treat this person presumptively for a urinary tract infection. And I'm actually treating them for STI, and I may send out the STD testing, but I'm telling the parent, if they ask, I'm treating for a urinary tract infection, which is true. It's affecting the urinary tract in some way, shape, or form. So you have to kind of play the game a little bit. If I'm significantly, like if this kid is saying my mom is going to kill me if she finds out, and you truly believe that the mom or dad has that capacity, then of course I'm going to try to get the health department involved in trying to get them confidential testing. But sometimes we can bypass the system with billing, just either in the office and letting our risk team know that we're trying to bypass this for the patient, or sending them to a place that can offer one. Almost nothing is 100% confidential, right? So we can offer them the best confidentiality that we can serve to them in that case.
Thank you. Thank you as always for sharing your expertise and information. So that's all the time we have for our presentations. Excellent. And I've got some, so thank you, Dr. Crew. We appreciate you.
Thank you.
So I'd like to thank all of our attendees for joining us today. And to close out, I have some final reminders and announcement. So as we begin to transition here, the important things with our CME credit and how to obtain those. If you have not already done so, please follow directions on the screen to claim your CME credit. Just to record your credit by text. If you missed any of today's presentations, we'll post a recording on the CHOR website within a few weeks. After the conclusion of today's events, you'll need to go into the CE Cloud website to complete your evaluation and finalize claiming credit. You have 45 days to submit your evaluation. We'll be using your responses in our evaluation to plan next year's agenda. So if there's a topic you'd like to learn more about next year, we'd love to hear that from you so that we know that we're bringing you the information that you would like to hear. In addition to that, to claiming your credit, we want to announce our save the date for our pediatrics at the Virtual Beach Conference this year. It's currently planned for July 17th and 18th of 2021, and we hope you can join us later this year. Again, we are grateful for you. We're so grateful that you're able to join us for this year's Clinical Challenges in Primary Care. At this time, we'll conclude today's event. Be well, and thank you again for your presence with us. We hope you have a great day.